It is societal action group of experts. It is an informal, voluntary organizations of the expert, retired professors, scientists, medical professionals, IT graduates from the, I think, the diverse background. The purpose is to see that government could get a sensible suggestion through our interaction, webinars, and see that the COVID pandemic is effectively managed in state of Karnataka. And many our good friends from different parts of India also have joined hands with us to see that such an initiative should take place in different parts of India. For example, IIM Ahmedabad, some professors, some Chennai, like that, people have joined hands with. This is an informal, voluntary forum. We have conducted first program exactly a month back on a very key issue of how to unlock Karnataka. This is second in nature, and this is focusing exclusively on the primary health area in rural Karnataka. And it's not just looking ನಮ್ಮ ಸರ್ಕಾರವನ್ನು ಮಾತ್ರ ನೋಡೋದು ಅಂತನೂ ಅಲ್ಲ. ಈಗ ಅವ್ರ ಫೋಕಸ್ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ವ್ಯವಸ್ಥೆ ಕರ್ನಾಟಕದ್ದು, looking at sectors other than the government. So I think this is a crucial issue for the today's meeting. Ivaga government is doing its level best. A pandemic is a challenge not only on government, it's a huge challenge on massive scale. It's a global scale, no doubt. Just bring you to kind notice a recent World Bank report precisely focusing on how to manage primary health care of across the world. It has made an excellent observation. As per the report, it is very candid in admitting that it is a failure in managing the COVID pandemics at the global level. Failure happened at all levels. At the global level to manage, coordinate the world bodies like World Health Organization. At the nation level, it is the rich nation or the poor nation, east or west, they could not manage to provide the proper governance. Corporate sectors has crippled. And above all, very interesting observation of the World Bank report is that the failure at individual behavior. ಈಗ ನಾನು ಹೊರಗಡೆ ಹೋದ ತಕ್ಷಣ ನಾನು ಫೋಟೋ ಕಳ್ಸಿಕೊಟ್ರೆ, ವಿಡಿಯೋ ಕಳ್ಸಿಕೊಟ್ರೆ ನನ್ನ ಫ್ಯಾಮಿಲಿ ಅಬ್ಸರ್ವ್ ಮಾಡ್ತಿರ್ತಾರೆ, ಲುಕ್ ಅಟ್ ಹಿ ಇಸ್ ನಾಟ್ ವೇರಿಂಗ್ ದಿ ಮಾಸ್ಕ್. ನಾವು ಹೊರಗಡೆ ಹೋಗ್ಬಿಟ್ಟು the moment we get into outside, we just forget. It is a failure at all level. So World Bank has admitted, and also say the primary health COVID has taken over the primary health care. Keeping that, it's a very recent World Bank report. My good friend Venugopal has forwarded it. Keeping this failure in mind, there is no point in putting more pressure on the government, criticizing on the government and pinpointing. I don't think so. It's the government alone can do that. But keeping this in mind, which is the other sectors, I took the liberty, I think Professor Gupta will support us, to define another sector called the social sectors. Who are these people? Several NGOs. Shama is heading one, Swasti catalyst. To our good friend, Kurupur Shantakumari, a farmers leader from Mysore, he formed Corona Seva Pade. Who are these people? By definition, they are the non-governmental organization. What are their purpose? They are the non-profit making organization. Non-government, non-profit making organization, it may be NGO, civil society, trust, all these are playing a very crucial role. I think both Shama and Madam will throw more light on that. We have to give more space to this. Samajika Valya, we have to give more space for this one. Of course, we have to make best use of the corporate social responsibility. CSR, I think, Madam, this is the time to expand genuine corporate social responsibility. Other than 2 or 3% profit over that one, it appears to be very technical. I think Professor Gupta is the right person to enlarge the scope of corporate social responsibility. Keeping this in mind, focus is on rural healthcare system of Karnataka, making use of the social sectors. This webinar has been called, webinar has been arranged. So, ನಮ್ಮ ಮುಂದೆ Professor Anil Gupta ಅವರು is a retired professor of IIM Ahmedabad. He is a founder member of National Innovation Foundation. I think he can provide. He worked extensively with the civil society, himself heading a Swasti and NGO. He has extensively worked with both corporate sectors as well as social sector. Hopefully, he can provide more about the conceptual framework for what he meant by social sector, how the CSR. It's only expectation from him. Then we have Miss Shama Karakal. She's from Karakal. So she is actually in rural healthcare sectors. She is heading. She is the head of Swasti Catalyst Foundation, and she is having the extensive knowledge, experience of working with the rural sectors. Hopefully, she can narrate ಅವರ ಒಂದು ಅನುಭವವನ್ನು ಕೂಡ ಹೇಳಬಹುದು ಅಂತ ನಾನು ಭಾವಿಸ್ತೇನೆ. ಶಮಾ ಕಾರ್ಕಿಲ್ ಅವರು ಮತ್ತೊಬ್ಬ ಮುಖ್ಯ ಭಾಷಣಕಾರರು. Then Prashanth Srinivas. Right now he has already joined, and right now he is in the remote area, tribal area of the BR Hills. Prashanth is from. I just had a discussion. He is from one of the key research institute in Bangalore. I think at this point of time, Institute of Public Health, Bangalore. We have requested him. He is already working in the rural areas. He knows better than anyone else. What is the problem faced by the rural health system, with special focus on the PHCs. These are the key speakers. We are having very important guest ನಮ್ಮ ಮುಂದಿದ್ದಾರೆ. ಶ್ರೀಮತಿ ಗೀತಾಂಜಲಿ ಕಿರ್ಲೋಸ್ಕರ್ ಅವರು. We came to know about her recently in Deccan Herald, and I'm thankful to Shama Karakal for convincing her and to see that she is very much here. She hails from one of the reputed industrial house, Kirloskar House, and she is very much in Bangalore. And very recently, a panel has been formed to assist the government in terms of the CSR support to the healthcare sectors of Karnataka. I just read in the newspaper. And we thought, she is the right person. We are a bit hesitant to invite her because it's something, a different forum. And she is very happy and coordinated. She expressed her willingness to see that, I should spend time. And also she said, I'm keen to listen to all of us. So I welcome you, madam. With all your busy schedule, you are very much with us.
No, not busy at all. Thank you so much.
Okay, that's fine. ಈಗ ನಾವು ಮೂವರು ಮುಖ್ಯ ಭಾಷಣಕಾರರಿದ್ದಾರೆ. ಭಾಷಣ ಆದ್ಮೇಲೆ ನಮ್ಮ many people would like to have interactions and questions and opinion. It's not directly through the moderated. I have requested my good friend Pratap Hegde. He is an IT expert, management person, to coordinate and see that the questions and interactions are properly analyzed and put before the three main speakers. So whatever Professor Gupta has just mentioned, all this discussion should reach to a place where it's supposed to reach and supposed to implement. We are referring to the government. We have one very important, sensible person from the ruling political party, BJP, Mr. Ganesh Karnik. He was two-time MLC, and he is capable of understanding and everything, and see that it will reach the government. That's what the expectation from him, and over and above his own experience. So I welcome Ganesh Karnik ji also, and we can approach government not only directly and indirectly to a sensible, responsible opposition parties also. Mr. V.R. Sudarshan, he is a key member of ruling opposition Congress party in Karnataka, and he had very long experience of very well managed upper house, in his capacity being the chairman of Karnataka Legislative Council. I think the longest term, 2 terms he has managed very well. These both are very exceptional. Both are my good friends, so I take the liberty to introduce them as exceptional politicians, very sensible, and they can definitely do justice to what is expected from them. And more important, any rural discussion, issues related to the rural sector is incomplete unless we have somebody from the rural area, somebody from the background of farming, somebody from the, keeping that in mind, we are having 3 or 4 important persons. I don't know whether they have joined or not. One is in a rural area should be represented in terms of, I'm from academic background, let us see that how in a systematic way it can be presented. So rural area, in my opinion, should be represented by the farmers. Majority of people are the farmers, somebody from the farming community. Followed by that is the rural women issues, very important. I think both Shamaji and Gitanji would appreciate, the women issue is very important. And the agriculture workers, unorganized sectors are equally important. And the rural youth, I think keeping these 4 key segments of the rural Karnataka, we have invited Mr. Kurubur Shantakumar. He's a farmer leader. Anytime, I think whether he has joined or not, anytime he may join, he will join. He is heading a sugarcane farmers association. And very interestingly, he formed very recently to provide all services during the COVID time through farming. What is known very interestingly, COVID Corona Save Pade, a warrior group of the Corona, to see that in the farmers, the rural people would get all the necessary. He is very much with it. Srimati V. Gayatri, I think she is having her own campaign called Nammura Bhumi Namagirali Anyarigala. In the backdrop of the farmers losing the land, especially keeping the women perspective, V. Gayatri is doing a huge campaign to see that farmers won't lose land because of the various pressure from outside, and see that in the agriculture become very prosperous, sustainable. And she's working on the organic farming. She is a part of an institute called Institution for Cultural Resistance Action. Hopefully, she will represent the rural women perspective. Abhay Kumar is right now working in the remote villages of Hyderabad, Karnataka, Raichur, working with the agriculture laborers, rural laborers, doing justice in terms of Narega. I think he has assured that I'll definitely join. I think he might have joined. And the rural youths. Prasanna N. Gowda is an engineering graduate working closely with the farmers, providing all support in terms of the water conservation. And now, he's coordinating with the various farmers organization, doctors, medical professionals to see that, rural people would get justice. ಇವರು 4 ಜನ ರೂರಲ್ ಪರ್ಸ್ಪೆಕ್ಟಿವ್ ಇಂದ ಮಾತಾಡ್ತಾರೆ. ಈಗ ಕೆಲವರು ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡಬಹುದು. ದೇರ್ ಇಸ್ ಐ ಥಿಂಕ್ ಐ ಹ್ಯಾವ್ ರಿಕ್ವೆಸ್ಟೆಡ್ ಬಾಲ ಸಂಗಮೇಶ್ವರ ಟು ಟ್ರಾನ್ಸ್ಲೇಟ್ ದಿ ಕೀ ಪಾಯಿಂಟ್ಸ್ ಎಮರ್ಜ್ಡ್ ಔಟ್ ಆಫ್ ದೋಸ್ ಹೂ ಸ್ಪೀಕ್ ಇನ್ ಕನ್ನಡ. ಬಹುಶಃ ಹೆಚ್ಚಿನವರಿಗೆ ಇಂಗ್ಲಿಷ್ ಅರ್ಥ ಆಗುತ್ತೆ ಅಂತ ನಾನು ಭಾವಿಸ್ತೇನೆ. ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ಸರ್ಕಾರಕ್ಕೆ, in addition to reaching this whatever emerge in the salient issues, conclusions, recommendation, we need the help of the media, print media, electronic media, and few social media also have agreed to record and join. I think I welcome the media person also, and the whole proceedings will be they recorded through YouTube, and later it will be available for anybody for that matter. This is how the today's program has been planned. Iga modalu I request 3 key speakers to take not more than 15 minutes, and if you have the PowerPoint, you can make a presentation. Followed by that, there will be question and answer. Pratap will moderate that one, and the response. Before that, Madam Gitanjali ji, you feel whenever you feel that you can intervene. You can make your point. It's up to you, madam. Let us hear the 3 key speakers first. Okay. Pratap, anything I left out?
No, sir, we can go ahead and
okay, we can go ahead.
Start with the first speaker.
Now, I will invite Professor Anil Gupta. We have specifically asked him to see that, how social sectors in strengthening the rural health system with the support of CSR. This is the subject we have asked Professor Anil Gupta. Now I invite Professor Anil Gupta.
Thank you very much, Prakash. Thank you. I'm so happy that you have brought a very diverse group of interested stakeholders together. And I have no doubt that this meeting will generate some very productive results. Now, I happen to be earlier the member of the high-level committee on CSR, which modified the guidelines and introduced several new ways in which it became more mandatory and also became much more efficient in allocating resources for innovation-based interventions in various sectors. I have also, as Prakash knows, we walked together in Kopa region in Karnataka, Malnad region, and we have walked in every state of the country on foot in summer and winter through Shodh Yatras, which Honeybee Network has been organizing every summer, every winter, to learn firsthand as to how people solve problems with their own genius. Given this background and given the experience with Gyan and Swasti and earlier with National Innovation Foundation, let me begin with first submission about ASHA worker. You know, a system is as strong as its weakest link. And two of the weakest link of our health system, which COVID-19 has demonstrated unequivocally, are the weakness of the primary health center and weakness of the skills and resources of ASHA worker. Now, ASHA workers need retraining, they need re-equipping, and they need upgrading their skills. And I was talking to the Niti Aayog Vice Chair also a few days back that we should request each company to take one taluka at least. The bigger companies could take one district, but at least one taluka, which is manageable, about 100 villages. And there can be a joint minimum core curriculum or pedagogic content which will be delivered to every ASHA worker about safety, about hygiene, about preventive health, about precautions that COVID requires if third wave, God forbid, comes, and various other protocols that are required, including the need for vaccination and overcoming the hesitancy. It is tragic that they get very low salary. So I would request that if the companies could match what government gives, generally 3,000 to 5,000 rupees is all that they get. So if corporate sector could complement it with new responsibilities, new accountability, new kind of skills, it will make a great difference to the health sector of our country. Now, having done that, what are the skills that the ASHA workers would need? It is ironic but true that Karnataka is a hub of medical devices, of biotech enterprises, of a whole range of diagnostics. The largest number of companies, if they have come out from any one state, it is from Karnataka. And yet, if you think of it, not one device is available at primary health center. Not one device or kit is available with the ASHA worker. Now, the so-called home kit is nothing but antigen test, which many of you must have taken. It is not very accurate, as you know. If it is positive, then it is all right. But if it is negative, there are chances, 60 to 70% chances that it may be a false negative. But even with that limitation, it is very easy to perform tests, as some of you might have done at various health centers or various places. And ASHA workers can easily be trained in that. And this kit costs nothing. And there are about 20 and odd entrepreneurs, a very large number from Karnataka, who all have this technology. And CC Camp, a body of NBRIC, which is set up by the Department of Biotechnology, has already started the effort of setting up an app which can be linked to the national database of tests, so that any test which is done in any village will also be uploaded on the national database with whatever result one gets. So it is very important that we train the ASHA workers and primary health center workers to perform the diagnostics and other tests which are possible. Third point, which is very important, is the point of care devices. Now, it is possible, for example, Sanket and many other enterprises are there which have developed a pocket size, this size of ECG machine, which can give you 12 lead. You keep at each point for 15 seconds and you get 12 lead ECG on your phone, and which can be then transferred to the doctor if need arises. Because post-COVID complications are no less serious than the COVID complications. We all know different kinds of problems that are arising, problems in bones, problems in fungal infection, problem in heart disease, problem in clotting. So many problems are coming, and the competence at the district level, or for that matter at the taluka level or village level, is not there at all practically for looking at those problems, and timely communication between the health worker and the health department or hospitals will be only possible if they are incorporated in telemedicine system. Karnataka is the IT hub of the country. I mean, IT revolution began from Karnataka, so it is not a big deal. In 24 hours, if you ask IT companies to sit together and perform and develop this, they will not only develop the kit, but they will also develop training modules so that within 3 or 4 hours, every ASHA worker can be trained to use the POCs, point of care devices. We should now make a complement. For example, even oximeter is not available. Even thermometer is not available many times. So what are we talking about? So naturally, every health worker should have a minimum complement of diagnostic and other tools, which will help us cope with the COVID and post-COVID situations. And this is doable, and we can do that. One more precaution I must suggest, health workers are not provided health insurance, unfortunately, many times. And we need to cover all of them through health insurance. Again, the company which takes responsibility for a taluka should get all of these done. Our frontier workers, our health workers, our sanitation workers must get health insurance, because we know how much expenditure people have had to commit. Even middle class people have had to commit. 1 lakh a day was the hospitalization charges in Karnataka, in Bangalore. And imagine the one episode and your savings of the last so many years are wiped out, and you're in fact under debt. So we must provide some way of dealing with the debts of these workers particularly, but also other people. Now comes the next issue. How do we ensure that the primary health centers work more efficiently than they have done so far? Now we have 2 major resources. Dr. Devi Shetty also mentioned about it. We have medical students and we have nurses, and they are given training. And if every student is required to have rural training as a part of their curriculum of 5 years MBBS, and Prakash would like this idea, I'm sure, with his daughter is doing post-graduation, that no seat in post-graduation should be given unless and until a student has spent minimum time in rural primary health center. You have to spend minimum 500 hours or 1,000 hours in a primary health center to become qualified for a PG admission, which means we will now get all those students who want to specialize, who want to get PG admission, postgraduate admission, working in primary health center, because that is important for them. They will learn firsthand the problems of the society that we are facing. And at the same time, they will get the mentoring of the best of the doctors. And I'm sure if the top senior scientists make a mentoring group to answer their questions and help them to learn from the communities and the health workers, I think it will be a very useful step where corporate hospitals, private sector hospitals, and government hospitals can come into the picture. It is also important, third point that I want to mention is, you mentioned about a community COVID center. In many parts of Gujarat and many other states, community COVID centers were very helpful. I think we need to create community health centers for infectious diseases. There are various kinds of infectious diseases which are expected to increase, and the isolation is the safest and the cheapest way of containing the problem. And we don't have that facility. In a small hut, one person lives in one hut, one family. How can they isolate? They don't have even one more room. So how would they separate? So some of the communities, what they did, they made a hall. Generally, marriage hall is there, or sometimes school was available, converted into COVID health center, and provided the care, one nurse and doctor on visit or doctor on call, and thereby we could cover entire village. Doctor had to go to every house otherwise if he goes to village. Now he has to go to the concerned cases only in one hall. So his time is saved, and the time of the health workers is also saved. So that's another thing that we should do. And it is very easily possible that we will be able to do. It was mentioned, Prakash mentioned about Manrega. In Manrega, we are supposed to provide 100 days of employment, but actually average is about 50 days, less than 50 days. So can we allocate 10 days for strengthening the hygiene and sanitation and waste management at each community level? Because these are, open air disposal of PPEs and all the other waste. And we must provide PPEs to these workers and ensure that under Manrega, we will make sure that no village will have potential for infections and the organisms to multiply. And, even today, the medical waste in the villages and primary health center is disposed in a very responsible manner. So we should create a consciousness. It will be an educational value. When people do it once, they will always try to remember and keep it forever. So we should use this pandemic as an opportunity of changing the health behavior and health habits of our community forever. We are going to make this investment because in our country, unfortunately, we only wake up when there is a fire. Now that there is a fire, can we wake up and make our health system and health behavior and health protocol and health practices ideal? So, for example, every Manrega worker will get soap along with the payment, wages, so that they wash their hands. And it's not a big deal. I've been writing about it for ages. Why can't we give every health worker a soap so that they can and method of how to wash their hands properly. Now, we should also try to now think of how can health centers, primary health centers, generate revenue. And there is a suggestion that I will give. All these startups in the health sector need to generate data on the robustness of their solutions, be it software solution, be it their hardware solution. Today, there is no platform to provide primary health centers access to this startup and startups access to the primary health centers. If these under CSR, we can create a highway, a connection between corporations and communities through the enterprises, then what will happen when public procurement has to take place? Karnataka government say, okay, your device is good, but how many places have you tested? The startup says 5 places or 3 places. And then the public administrator does not show interest and give order to a big company. Now, it is useful if we generate data. So for example, if there is a diagnostic kit, then the diagnostic kit should be tried in 1,000 or 100 primary health centers in different districts. And we should train our health workers in collecting data on the use patterns, on the results, and give it back. This data collection and delivery will be a paid service, for which either entrepreneur or Karnataka government or corporations or Department of Biotechnology or somebody will pay, ICMR, somebody will pay for the fact that our workers are doing some additional work of collecting data. There are 2 advantages. Workers will come to know the robustness of these solutions, and our entrepreneurs will get to have real data in real life. How will my device work? How will my solution work? So this could be a very useful solution. I will give you one example. We give Gandhian Young Technological Innovation Award to young innovators. And one of the award was for Steri Freeze. That means if you don't have autoclave in a primary health center, you know that the devices that doctors use, forceps and various other spatula and so on, these need to be disinfected properly. And many times autoclave is not there, or the electricity is not there, or some problem. So this is a small device, a box of 200 rupees, put a liquid in about 100 rupees liter liquid. You put the devices for 2 minutes in this liquid and they get disinfected. Very low cost solution. Now, such solutions will need to be provided at primary health centers so they don't spread the infection. It is true for general time, but it is also true now. Finally, 3 points and then I close. First, another point, 6th point is that Ayurveda has its own importance. I am a regular user of Ayurvedic medicine, Ayurvedic kadas and Ayurvedic preventive health medicines. Now, there is no harm in blending Ayurveda with allopathic care. I would say even yoga to be also introduced in the health service. So when we give charts to the health worker, we also give yoga chart. We also give them Ayurvedic charts, food, which season, what food to avoid, what food to take, which will produce cough, which will produce vata, which will produce pitta. So these are simple things. I mean, these are not very complicated. These are not something which requires a doctor's advice. These are self-care practices of preventive health. And we can easily provide this information to our health workers at the village level, and that will generate better healthcare. 7th point is that we often pay attention to places where there's a problem, but we don't learn from the places where there is no problem. So villages which have had no accident or no adverse consequence or no COVID case, villages which have no sickness, no hospitalization in the last 5 years, we should focus on those villages and study how come that this village has not had one person going to hospital. Must be something right. They're doing something right. They're eating right. They're growing right. Their agriculture, their food, their health connection must be wide. Their water must be good. There must be something happening in this community which we need to learn from. So while I'm not saying we should not pay attention to the sickness, but we should also pay attention to the health, the healthy communities, healthy people. And this will be very useful. Last point is, I did a study on soil health, crop health, animal health, and human health with the help of 15, 20 doctors, agriculture scientists, livestock scientists, in 2 villages where chronic disease were more and 2 villages where chronic disease were less. And we found we wanted to connect soil minerals which are uptaken by the crop, which is uptaken by the livestock as fodder and human as grain, and did a study of plasma blood samples of the human beings, animals, and food analysis and so on. And we found in this case, it was a pilot study, that copper was one mineral which explained the discrimination between the villages having, or people having less chronic disease versus more. Now, if there are such cases, then obviously the food grown in those soils which are mineral rich, such as in dry region, Chitradurga and other places, is a functional food because it has more minerals. And if people with arthritis, for example, if they consume boron-rich food, they will not have to take too much medicine. So if we can encourage such studies also done, and where the researchers, the corporations can underwrite some of these studies as a part of their CSR activity, and we focus on how we can link agriculture, health, and of course hygiene and other care system, it would be wonderful, because then our farmers will also get connected to this effort of health, which I know both Prakash and all of you are very keenly involved in. I will close by saying that there is a great opportunity with Sister Loskar and other people present here, and people with the political system also present here, and social sector available here. Our social sector can fill the gaps in linkages. Where linkages are missing, we will provide those linkages. But more importantly, the corporations have to provide that seamless connectivity in various points that we are talking about. Good quality data, good quality analytics, good quality communication, good quality connectivity is fundamental for any effort to be made where our health workers, their knowledge, their understanding of the system, and our policymakers can be improved in real time. Thank you so much.
Thanks, Professor Gupta ji. Your vast experience, not only being part of an academic institution, research institution, part of the government, through your Shodha Yatra, you walked breadth and throughout the India, nuclear corners of India, and with vast experience speaks itself. Very valuable suggestions, very sensible suggestion. Definitely, I think it's worth considering. Now I invite Dr. Prashanth. Prashanth ಅವರು ರೆಡಿ ಆಗಿದ್ರೆ I think he's from the remote corner of Karnataka. BR Hills ಇಂದ ಬರ್ಬೇಕಾದ್ರೆ. Prashanth, are you ready? Prashanth, can I hear you? Yeah. ಈಗ ತಾವು ಮಾತಾಡಿ. ಈಗ I think probably Prashanth. Yeah, definitely. ನಿಮ್ಮ ಮಕ್ಕ ಸರಿಯಾಗಿ ಕಾಣ್ತಲ್ಲ. Anyhow, your PowerPoint slides will be exhibited. Either you are going to exhibit or yourself, or ನೀವು ಹೇಗೆ ಮ್ಯಾನೇಜ್ ಮಾಡ್ತೀರಿ ಇವಾಗ? Do you need my assistance?
Can I request someone to do it? Ili correct? Can someone please?
Naveen, are you ready? ನೀವು ಮಾತು ಸ್ಟಾರ್ಟ್ ಮಾಡಿ, ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡಿದ್ರೆ ಮತ್ತೆ. Fine. So ಈಗ ನಾನು ಪ್ರಶಾಂತ್ ಅವರನ್ನ, Prashanth is from Institute of Public Health, Bangalore. He will speak on an overview of PHCs and lessons learned in COVID-19 crisis in rural Karnataka. So I welcome Prashanth.
ಥ್ಯಾಂಕ್ ಯು. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನನ್ನ ಹೆಸರು ಪ್ರಶಾಂತ್ ಅಂತ. ನಾನು ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಬೆಂಗಳೂರಲ್ಲಿ ಕೆಲಸ ಮಾಡೋದು. ಬಟ್ ನಮ್ಮ ಕೆಲಸ ಹೆಚ್ಚು ಚಾಮರಾಜನಗರ ಜಿಲ್ಲೆ ಬಿಳಿಗಿರಿ ರಂಗನ ಬೆಟ್ಟದಲ್ಲಿ ನಡೆಯೋದು. ಇಲ್ಲಿ ಒಂದು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ರಿಸರ್ಚ್ ಫೀಲ್ಡ್ ಸ್ಟೇಷನ್ ಅಂತ ಮಾಡಿ ಸುಮಾರು 4-5 ವರ್ಷದಿಂದ ನಾವು ಇಲ್ಲೇನೆ ಕೆಲಸ ಮಾಡ್ತಾ ಇರೋದು. ಫಸ್ಟ್ಲಿ ತುಂಬಾ ಧನ್ಯವಾದಗಳು ಫಾರ್ ಇನ್ವೈಟಿಂಗ್ ಮೀ ಟು ದಿಸ್ ಕಾನ್ವರ್ಸೇಷನ್, ಅಂಡ್ thank you very much to the professor who has given us a wonderful overview of what difficulties exist with strengthening rural health. I would like to offer, I don't think I will take 15 minutes. I will try to complete earlier so that we have more time for interaction. But nandu main ಏನಂದ್ರೆ ಒಂದು ದೃಷ್ಟಿಕೋನ, ಈ ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಕೇರ್ ಮತ್ತೆ ಸೋಷಿಯಲ್ ಡಿಟರ್ಮಿನೆಂಟ್ಸ್ ಆಫ್ ಹೆಲ್ತ್ ಅಂತೀವಲ್ಲ, ಇಂಥ ಒಂದು ದೃಷ್ಟಿಕೋನ ಹೇಗೆ ನಾವು ಇನ್ಕಾರ್ಪೊರೇಟ್ ಮಾಡ್ಕೋಬಹುದು ನಮ್ಮ ರಿಫಾರ್ಮ್ಸ್ ಅಲ್ಲಿ ಅನ್ನೋ ಒಂದು ದೃಷ್ಟಿಯಿಂದ ನಾನು ಮಾತಾಡ್ತೀನಿ. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಪ್ಲೀಸ್ ನವೀನ್. ಸೊ ಆಕ್ಚುಲಿ ರೀಸೆಂಟ್ ಆಗಿ BMJ ಗ್ಲೋಬಲ್ ಹೆಲ್ತ್ ಅನ್ನೋ ಜರ್ನಲ್ ಅಲ್ಲಿ ನಾವು ಒಂದು ಕಾಮೆಂಟ್ರಿ ಪಬ್ಲಿಷ್ ಮಾಡಿದ್ವಿ. ಸೊ ದೇರ್ ಕಾಮೆಂಟ್ರಿನಲ್ಲಿ we of course point out this thing that the fact that there is COVID-19, the crisis is often in various systems, has been identified as an opportunity for change. That's one thing everyone talks about, be it within families, neighborhoods, or within nations. So that is fantastic. However, one of the things that we offer in this paper that we wrote is that we must focus on governance. So now one of the easiest ways to lose focus of the reforms process is to think that the crisis is about numbers or coverage or cost. And I think that's the fundamental sort of value underlying the reforms that we tried to highlight in this paper that we wrote. And what is it that we should focus on within governance ಅಂತ ನೋಡಿದ್ರೆ, next slide please, Naveen. Naveen, if possible, make it full screen so that some of the smaller text will become a bit more visible. So one of the key things that we would like to offer to this conversation of reforms is that we must make a clear distinction between individual health and public health. And sadly, this one focus has been lost in our response. Take, for example, the constitution of expert committees and task forces for averting this crisis or for helping us prepare better. It is entirely packed with specialist doctors. Typically, somehow policy makers have a predilection for cardiologists and cardiothoracic surgeons, but generally the idea is this time they have had pediatricians. So I think the logic underlying ಏನು ಒಂದು ಪಾಲಿಸಿ ಮೇಕರ್ ಅವರ ಒಂದು ವಿಚಾರ ಏನಿದೆ ಅಂದ್ರೆ, ಇದರಲ್ಲಿ ಒಬ್ಬ ಡಾಕ್ಟರ್ ಇದ್ರೆ ಅವರು ಇಂಡಿವಿಜುವಲ್ಸ್ಗೆ ಟ್ರೀಟ್ ಮಾಡ್ಬೋದು, ಹಾಗಾಗಿ ಅವರು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ನು ಅವರು ಹ್ಯಾಂಡಲ್ ಮಾಡ್ಬೋದು ಅಂತ ಒಂದು ಅಸಂಪ್ಷನ್ ಬರುತ್ತೆ. But what we know is public health is an entirely different discipline from clinical medicine. Public health, health of populations ಗೆ ಬೇರೆ ಬೇರೆ ರೀತಿಯಂತಹ ಒಂದು ಫ್ರೇಮ್ವರ್ಕ್ಸ್ ಬರುತ್ತೆ. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಎಪಿಡೆಮಿಯಾಲಜಿ ಅಂತೀವಿ, ಡಿಸೀಸ್ ಡೈನಾಮಿಕ್ಸ್ ಇರುತ್ತೆ, ಮತ್ತೆ ಆಂಥ್ರೋಪಲಾಜಿಕಲ್ ಇನ್ಪುಟ್ಸ್ ಬರುತ್ತೆ. ಯಾಕೆ ಕೆಲವು ಸಮುದಾಯಗಳು ಆರೋಗ್ಯ ಸೇವೆಗಳನ್ನ ಪಡ್ಕೊಳ್ಳೋದ್ರಿಂದ ಹಿಂಜರಿಕೆ ಬರುತ್ತೆ. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಆದಿವಾಸಿ ಸಮುದಾಯಗಳಲ್ಲಿ ತುಂಬಾ ಒಂದು ಟ್ರಸ್ಟ್ ಇಶ್ಯೂಸ್ ಇದೆ. ಸಿಸ್ಟಮ್ನ ಅವರು ಪಕ್ಕದಲ್ಲಿ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ ಇದ್ರೂ ಅದನ್ನ ಬಳಸ್ಕೊಳ್ಳೋದಕ್ಕೆ ತುಂಬಾ ಹಿಂಜರಿಕೆ ಇರುತ್ತೆ. ಸೊ ಇಂಥದನ್ನೆಲ್ಲ ನಾವು ಸ್ಟಡಿ ಮಾಡಬೇಕಾದ್ರೆ ನಾವು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಫ್ರೇಮ್ ವರ್ಕ್ಸ್ ಬೇಕಾಗತ್ತೆ, ಬೇರೆ ಬೇರೆ ಒಂದು ದೃಷ್ಟಿಕೋನಗಳನ್ನ ಅಪ್ಲೈ ಮಾಡಬೇಕಾಗತ್ತೆ. ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಅವು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಆರ್ ಕ್ಲಿನಿಕಲ್ ಮೆಡಿಸಿನ್ ನಲ್ಲಿ ಅದರ ಒಂದು ಹೆಚ್ಚಾಗಿ ವಿವರಣೆ ಇರೋದಿಲ್ಲ. ಟೇಕ್ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ದ ಇಶ್ಯೂ ಆಫ್ ಜೆಂಡರ್ ಅಲ್ಲೂ ಜೆಂಡರ್ ಎಡ್ಯುಕೇಶನ್ ಇನ್ medical school, for example, is severely still lacking, and various other social determinants. Take, for example, the issues of that people face, such as the fact that there is still many communities still do face caste discrimination. There is also class-based discrimination often, which happens in public services. So these are all important realities that affect some of our population, but not all of our population. Hence, one of the things that we try to offer from public health is, please make a distinction between individual health to public health. Next slide, please, Naveen. ಸೊ ಇದನ್ನ ಈ ಒಂದು ವಿಚಾರನ ನಾನು ಮುಂಚೆನೆ ಹೇಳಿದೆ. ಸೊ ಇನ್ನೊಂದು ನಮ್ಮ ರಿಫಾರ್ಮ್ಸ್ ಪ್ರಾಸೆಸ್ ಅಲ್ಲಿ ನಮ್ಮ ತಪ್ಪು ಏನ್ ಮಾಡ್ತೀವಿ ಅಂದ್ರೆ, ನಾವು ಪಾಲಿಸೀಸ್ ಮೇಲೆ ಫೋಕಸ್, ಇದು ಈ ಒಂದು ಸ್ಕೀಮ್ಗಳ ಮೇಲೆ ಫೋಕಸ್ ಮಾಡ್ಬಿಡ್ತೀವಿ. ಇವಾಗ ABRK ಸ್ಕೀಮ್ ಅಂತ ಒಂದಿದೆ, ಸುವರ್ಣ ಆರೋಗ್ಯ ಸುರಕ್ಷಾ ಯೋಜನೆ ಅಂತ ಇನ್ನೊಂದು ಸ್ಕೀಮ್ ಇದೆ. ಸೊ ಈ ರೀತಿ ಬೇರೆ ಬೇರೆ ತರ ಸ್ಕೀಮ್ಸ್ ಮೇಲೆ ಮಾತ್ರ ಫೋಕಸ್ ಮಾಡ್ಬಿಡ್ತೀವಿ. ಆ ಸ್ಕೀಮ್ ಮೇಲೆ ಫೋಕಸ್ ಯಾಕೆ ತಪ್ಪು ಅಂದ್ರೆ, ಸಮಾನತೆ ಮತ್ತೆ ಒಂದು ಈಕ್ವಿಟಿ ಅಂತೀವಿ. ಯಾಕಂದ್ರೆ ಸ್ಕೀಮ್ಸ್ ಆರ್ ನಾಟ್ ಅ ಫಿಕ್ಸ್ ಫಾರ್ ಸೊಸೈಟಲ್ ಪ್ರಾಬ್ಲಮ್ಸ್, ಬಿಕಾಸ್ ಸ್ಕೀಮ್ಸ್ ಟೆಂಡ್ ಟು ಟ್ರೀಟ್ ಎವ್ರಿ ಒನ್ ಈಕ್ವಲಿ. ಆ ತರ ಮಾಡೋದ್ರಿಂದ ನಾವು ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರಗಳ ಮಟ್ಟದಲ್ಲಿ ನಾವು ಏನ್ ನೋಡ್ತೀವಿ, ಎಲ್ಲಾ ಸಮುದಾಯಗಳು, ಎಲ್ಲಾ ನೇಬರ್ಹುಡ್ಸ್ ಒಂದೇ ರೀತಿಯ ಒಂದು ಇಂಟರ್ಫೇಸ್ ಇರೋದಿಲ್ಲ ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ ಜೊತೆ. ಸೊ ಅವಾಗ ಏನಾಗತ್ತೆ, ಈ ಸ್ಕೀಮ್ಗಳಲ್ಲಿ ಸುಮಾರು ಸಮುದಾಯಗಳು ಬಿಟ್ಟು ಹೋಗ್ಬಿಡ್ತವೆ. ಅಂಡ್ ಇನ್ವೇರಿಯಬ್ಲಿ ದೀಸ್ ಆರ್ ದ ಸೇಮ್ ಕೈಂಡ್ ಆಫ್ ಪಾಪ್ಯುಲೇಷನ್ಸ್ ದಟ್ ಆರ್ ಗೆಟಿಂಗ್ ಡ್ರಾಪ್ಡ್ ಔಟ್ systematically across decades. Yeah, so that's why I think we need to move beyond new and large popular schemes and move towards structural changes. And I will not leave it at this abstract level. In the last slide I will highlight a few structural changes that we can take up. Next slide please, Naveen. So that is why the idea is to adopt a public health approach. So public health is a discipline by itself. Unfortunately, reforms agenda setting and process ಅಲ್ಲಿ ಸ್ವಲ್ಪ ಮಟ್ಟಕ್ಕೆ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಸ್ವಲ್ಪ ಒಂದು ಸೈಡ್ ಲೈನ್ ಆಗಿದೆ ಅಂತ ಅನ್ಕೋಬಹುದು. ಇಂಥ ಒಂದು ಮಾಸ್ಟರ್ಸ್ ಇನ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅನ್ನುವಂಥ ಒಂದು ಕೆಲವು ಟ್ರೈನಿಂಗ್ಸ್ ನ ಇಂಡಿಯಾನಲ್ಲೂ ಸುಮಾರು ಕಾಲೇಜುಗಳಲ್ಲಿ ಬರ್ತಾ ಇದೆ. ಇವಾಗ JSS ಅಲ್ಲಿ ಇದೆ, KLE ಕಾಲೇಜಲ್ಲಿ ಇದೆ, ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಮಣಿಪಾಲಲ್ಲಿ ಟೀಚ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಆದ್ರೆ ದಿಸ್ ಇಸ್ ನ್ಯೂ ಇನ್ ಇಂಡಿಯಾ. ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಮತ್ತೆ ಪಬ್ಲಿಕ್ ಪಾಲಿಸಿ ಅನ್ನುವಂಥ ಒಂದು ಡಿಸಿಪ್ಲಿನರಿ ಟ್ರೈನಿಂಗ್ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಸ್ವಲ್ಪ ಕಮ್ಮಿ ಇದೆ. ಸುಮಾರು ಜನ ನಾವು ಇವಾಗ ನಾನು ನನ್ನ ಮಾಸ್ಟರ್ಸ್ ಇನ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅಬ್ರಾಡ್ ಹೋಗಿ ಮಾಡ್ಕೊಂಡ್ ಬಂದಿದ್ದೀನಿ. ಆ ರೀತಿ ಸುಮಾರು ಜನ ಕರ್ನಾಟಕದವರು ಆ ತರ ಹೋಗಿ ಬಂದು ಓದಿ ರಿಸರ್ಚ್ ಅದು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಇಂಥವ್ರನ್ನ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ರೆಸ್ಪಾನ್ಸ್ ಅಲ್ಲಿ ನಾವು ಇನ್ವಾಲ್ವ್ ಮಾಡ್ಕೋಬೇಕು ಅಂತ ನನ್ನ ಒಂದು ಅಪೀಲ್ ಇಲ್ಲಿ. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. ಸೊ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅಲ್ಲಿ ನಾವು ಹೇಗೆ ಅಪ್ರೋಚ್ ಮಾಡ್ತೀವಿ ಹೆಲ್ತ್ ಅನ್ನ? ನಾವು ಹೆಲ್ತ್ ಅನ್ನ ಒಂದು ಸಿಸ್ಟಮಿಕ್ ಆಗಿ ನೋಡ್ತೀವಿ. ಒಂದು ಹೆಲ್ತ್ ಅನ್ನೋದು ಒಂದು ಬರೀ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ ಬಿಲ್ಡಿಂಗ್ ಅಲ್ಲ, ಆಸ್ಪತ್ರೆಗಳಲ್ಲ. ಹೆಲ್ತ್ ಇಸ್ ಸಮಥಿಂಗ್ ದಟ್ ಗೆಟ್ಸ್ ಕನ್ಸ್ಟ್ರಕ್ಟೆಡ್ ಇನ್ ಸೊಸೈಟಿ. ಸೊ ಒಂದು ಸಮುದಾಯದಲ್ಲಿ, ಒಂದು ಸಮಾಜದಲ್ಲಿ ಯಾವ ರೀತಿ ಆರೋಗ್ಯ ಹೆಚ್ಚು ಮಾಡಿಸ್ಬೋದು ಅನ್ನುವಂಥ ಒಂದು ಸಿಸ್ಟಮ್ಗೆ ನಾವು ಹೆಲ್ತ್ ಅಂತೀವಿ. ಅದರಲ್ಲಿ ಸುಮಾರು ವಿಷಯಗಳು ಬರುತ್ತೆ. ಬರೀ ಸರ್ವಿಸ್ ಡೆಲಿವರಿ ಒಂದೇ ವಿಷಯ ಅಲ್ಲ. ಸೊ ಹೆಚ್ಚಾಗಿ ರಿಫಾರ್ಮ್ಸ್ ಅಲ್ಲಿ ವಿ ಟೆಂಡ್ ಟು ಫೋಕಸ್ ಓವರ್ಟ್ಲಿ ಆನ್ ವೇಕೆನ್ಸಿ ಫಿಲ್ಲಿಂಗ್ ಆರ್ improving buildings of PHCs or providing new equipments within PHCs. These are all within service delivery. But the entry points to health system and public health are so many others. Take for example the interface with population. ಹೇಗೆ ನಾವು ಇವಾಗ ಪ್ರತಿಯೊಂದು ಹಳ್ಳಿನಲ್ಲಿ ವಿಲೇಜ್ ಹೆಲ್ತ್ ಸ್ಯಾನಿಟೇಷನ್ ಅಂಡ್ ನ್ಯೂಟ್ರಿಷನ್ ಕಮಿಟಿ ಅಂತ ಇದೆ. ನ್ಯಾಷನಲ್ ಹೆಲ್ತ್ ಮಿಷನ್ ಹ್ಯಾಸ್ ಎಸ್ಟಾಬ್ಲಿಷ್ಡ್ ದೀಸ್. ಹೌ ಡು ವಿ ಮೇಕ್ ದೀಸ್? ಅಂಡ್ ದೇರ್ ಆರ್ ಸೋ ಮೆನಿ ಅದರ್ ಕಮಿಟೀಸ್. ಹೆಸರಿಗೆ ಸುಮಾರು ಕಮಿಟಿಗಳಿದೆ. ಕೊರೋನಾನಲ್ಲಿ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಪ್ರತಿಯೊಂದು ಗ್ರಾಮ ಪಂಚಾಯತಿನಲ್ಲಿ ಟಾಸ್ಕ್ ಫೋರ್ಸ್ ಮಾಡಿದ್ರು. We have a strong culture of decentralized organization building. However, how do we really enliven and capacitate these extensive grassroots committees? Idralli ನಾವು ಹೆಚ್ಚಾಗಿ ಫೋಕಸ್ ಮಾಡಿಲ್ಲ. So this will be part of what is called a system building. So ಈ system building ಗೆ we say in public health there is no silver bullet. So there is no amazing centralized reform that can be passed in Bangalore which will impact Bidar, which will impact Chamarajanagar. ಇದಕ್ಕೆ ನಿಜವಾಗಿಯೂ ಡಿಸೆಂಟ್ರಲೈಸ್ಡ್ ಗ್ರಾಸ್ ರೂಟ್ಸ್ ಕೆಲಸ ಆಗಬೇಕು. ಇನ್ ಅವರ್ ಪಂಚಾಯತ್ಸ್, ಇನ್ ಅವರ್ ನೇಬರ್ಹುಡ್ಸ್, ಆದಿವಾಸಿ ಏರಿಯಾಸ್, ವೇರಿಯಸ್ ಅದರ್ ಪ್ಲೇಸಸ್ ಈ ತರ ಕೆಲಸ ನಡಿಬೇಕು. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ನವೀನ್. ಸೊ ಅಂಡ್ ಇದನ್ನ ನಮ್ಮ ಪ್ರೊಫೆಸರ್ ಅವರು ಈಗ ತಾನೇ ಕೆಲವು ಹೈಲೈಟ್ ಮಾಡಿದ್ರು. ಸೊ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ, ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಚಿಕಿತ್ಸೆ ಅಥವಾ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ ಅಂದ್ರೆ ಅದು ಇಟ್ಸ್ ನಾಟ್ ಜಸ್ಟ್ ಅ ಕ್ಯೂರೇಟಿವ್ ಪಾಯಿಂಟ್. ಆಕ್ಚುಲಿ WHO ಅವರು 1970s ಅಲ್ಲಿ ಆಲ್ಮಾ ಅಟಾ ಡಿಕ್ಲರೇಷನ್ ಅಂತ, ಇಂಡಿಯಾ ಇಸ್ ಆಲ್ಸೋ ಸಿಗ್ನೇಟರಿ ಟು ದಟ್. That has been reaffirmed recently, and one of the key components when we say primary health center or primary health care is that a PHC becomes a hub not only for providing curative services but is also supposed to be a focus for organizing health prevention, health promotion and rehabilitative care. Not only physical rehabilitation but also psychosocial rehabilitation. Obviously this is a very tall order, but there is no other way. For example, I'm talking to you from Chamarajanagar district. Just yesterday we had a person who came with a 30-year-old wife who is suffering from cancer. She has had several cycles of radiotherapy and chemotherapy, but still palliative care, making palliative care available at village or remote areas falls onto the same ASHA. And the previous speaker ಚೆನ್ನಾಗಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದ್ರು. ಆಶಾ ಮೇಲೆ ಎಷ್ಟು ಬರ್ಡನ್ ಅಂದ್ರೆ ಕೊರೋನಾ ಇಂದ ಹಿಡಿದು ಮ್ಯಾಲ್ ನ್ಯೂಟ್ರಿಷನ್, ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಏನೇ ಇದ್ರು ಹಳ್ಳಿಗೆ ಒಬ್ಬಳು ಆಶಾ, ಆಕೆ ಮೇಲೆ ಪೂರ್ತಿ ಒಂದು ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ ಬರ್ಡನ್ ಅವಳಿಂದ ನಾವು ಎಕ್ಸ್ಪೆಕ್ಟ್ ಮಾಡೋದಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಹೌ ಕ್ಯಾನ್ ಶಿ ಪ್ರೊವೈಡ್ ಪ್ಯಾಲಿಯೇಟಿವ್ ಕೇರ್? ಹೌ ಕ್ಯಾನ್ ಶಿ ಪ್ರೊವೈಡ್ ಕೌನ್ಸಲಿಂಗ್ ಅಂಡ್ ಮೆಂಟಲ್ ಹೆಲ್ತ್ ಕೇರ್, ಅಡಾಲಸೆಂಟ್ ಹೆಲ್ತ್? ಸುಮಾರು ಚಾಲೆಂಜಸ್ ಇದೆ ನಮ್ಮ ಒಂದು ಹೆಲ್ತ್ ವರ್ಕ್ ಫೋರ್ಸ್ ಅಲ್ಲಿ. ಸೊ ವಿ ರಿಯಲಿ to realize real primary health care, which is not just curative services, we have to really empower the primary health centers much more than equipment and buildings. It really needs a much higher level of motivation, and we have to build their status. So people should feel pride about ನಮ್ಮೂರ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ, ನಮ್ಮೂರ ಶಾಲೆ ಅಂತ ಒಂದು ಮೂವ್ಮೆಂಟ್ ಮಾಡಿದಂಗೆ ನಮ್ಮ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ ಅನ್ನುವಂಥ ಒಂದು ಇದು ಬರಬೇಕು ಜನರಲ್ಲಿ. Next slide. So, and very quickly, PHC is also not the final solution, because PHC functions within a multi-tier health service. So so homes and neighborhoods, like the previous speaker mentioned, are also important places where health gets constructed. Traditional medicine irbodu, matte home level health practices irbodu. That is also something that we have to meaningfully invest in, because we have spent decades often telling that many things that people do at homes is superstitious. But unfortunately, we have not provided a modern fix for that. So we just take, for example, midwifery was an amazing tradition that was prevalent extensively in rural areas. Now we killed it. But have we substituted it with respectful maternity care? So ನಮ್ಮ ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರಗಳಲ್ಲಿ ಹೋಗಿ ಒಂದು ಚೆನ್ನಾಗಿ ನಂದು ಡೆಲಿವರಿ ತುಂಬಾ ಕಂಫರ್ಟಬಲ್ ಆಗಿ ಸೇಫ್ ಆಗಿ ಆಯ್ತು ಅಂತ ಎಷ್ಟು ಜನ ಹೇಳ್ಕೊಳ್ಳೋ ಅಂತ ಪರಿಸ್ಥಿತಿ ಇದೆ? ಸುಮಾರು ಕಡೆ ಈ ತರ ಹೇಳ್ಕೊಳ್ಳೋದಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಸೊ ಟು ಪ್ರೊವೈಡ್ ರೆಸ್ಪೆಕ್ಟ್ಫುಲ್ ಅಂಡ್ ಸೇಫ್ ಮೆಟರ್ನಿಟಿ in all primary health centers is a very basic thing, and that is yet to be reached. Yeah. ಅದೇ ರೀತಿ ಎರಡನೇ tier is sub centers and PHCs. ಇಲ್ಲಿ ಬೇಸಿಕ್ 70-80% ಆಫ್ ದ ಔಟ್ ಪೇಷಂಟ್ ಕೇರ್ ಎಲ್ಲ ಇಲ್ಲಿ ಆಗಬೇಕು. ಆದರೆ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಸೆಕೆಂಡ್ರಿ ಕೇರ್, ಸರ್ಜರಿ ಬೇಕಾಗಿದ್ರೆ ಮತ್ತೆ ಇನ್ನೂ ಒಂದು ಕೆಲವು ಸ್ಪೆಷಲಿಸ್ಟ್ ಆರ್ಥೋಪೆಡಿಕ್ಸ್ ಬೇಕಾಗಿದ್ರೆ ಅದು ತಾಲೂಕಾ ಮಟ್ಟದ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಆಗಬೇಕು. ಕೊನೆಗೆ ಇಲ್ಲಿ ಆಗದೇ ಇರುವಂತಹ ಕೆಲವೇ ಒಂದು 5-10% ಆಫ್ ದ ಇಲ್ನೆಸಸ್ ವಿಚ್ ರಿಕ್ವೈರ್ ಟರ್ಷಿಯರಿ ಕೇರ್, ಅವು ಮಾತ್ರ ಬೆಂಗಳೂರು ಅಥವಾ ಜಿಲ್ಲಾ ಮಟ್ಟದ ಆಸ್ಪತ್ರೆಗೆ ಹೋಗ್ಬೇಕು. ಆದ್ರೆ ಆ ರೀತಿ ಆಗ್ತಾ ಇಲ್ಲ. ಆ ರೀತಿ ಶಿಸ್ತಾಗಿ ಒಂದು ನ್ಯಾವಿಗೇಟ್ ಮಾಡುವಂತ ಒಂದು ವ್ಯವಸ್ಥೆ ನಮ್ಮಲ್ಲಿ ಇಲ್ಲ. ಸೊ ಅದರಿಂದ ಪೀಪಲ್ ಆರ್ ರಿಯಲಿ ಲಾಸ್ಟ್ ವಿದಿನ್ ಅವರ್ ಓನ್ ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್. ಅದರಲ್ಲೂ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ನಾವೆಲ್ಲ ಸ್ಕೀಮ್ಸ್ ಮೇಲೆ ಡಿಪೆಂಡ್ ಆಗ್ಬಿಡ್ತಿದೀವಿ. ಇವಾಗ BPL ಕಾರ್ಡ್ ಇದ್ರೆ ಎಲ್ಲಾದ್ರೂ ಪ್ರೈವೇಟ್ ಅಲ್ಲೂ ಹೋಗಿ ನೀವು ಆಪರೇಷನ್ ಮಾಡಿಸ್ಕೋಬಹುದು ಫ್ರೀ ಆಗಿ ಅನ್ನುವಂಥ ಒಂದು ಸ್ಕೀಮ್ ಇದೆ. ಆದ್ರೆ ನಿಜವಾಗಿಯೂ ನೋಡಿದ್ರೆ ಎಷ್ಟು ಜನ ಆದಿವಾಸಿ ಸಮುದಾಯದ ಎಕ್ಸಾಂಪಲ್ ನಾನು ಕೊಡ್ತೀನಿ, ಯಾಕಂದ್ರೆ ನನಗೆ ಇದು ಡೈರೆಕ್ಟ್ ಅನುಭವ ಇರೋದ್ರಿಂದ. ಎಷ್ಟು ಜನ ಆದಿವಾಸಿ ಸಮುದಾಯದವರನ್ನ ನಾವು ಮೇಲ್ಗಡೆ ಆಸ್ಪತ್ರೆ ಮೈಸೂರಿಗೆ ಅಥವಾ ಚಾಮರಾಜನಗರಕ್ಕೆ ಕಳಿಸ್ಬೇಕಾದ್ರೆ ದ ಅಮೌಂಟ್ ಆಫ್ ಟೈಮ್ ವಿ ಹ್ಯಾವ್ ಟು ಸ್ಪೆಂಡ್ ಟೆಲಿಂಗ್ ದೆಮ್ ದಟ್ ದೇ ವಿಲ್ ಡೆಫಿನೆಟ್ಲಿ ಗೆಟ್ ದ ಕೇರ್ is I just cannot explain. Why is that the case? Because many people have lost trust in public services. ಅಲ್ಲಿ ಹೋಗಿದ್ರೆ ಒಳ್ಳೆ ಗುಣಮಟ್ಟದ ಆರೋಗ್ಯ ನಮಗೆ ಸಿಗತ್ತೆ ಅನ್ನೋಂಥ ಒಂದು ಇದು ಹೋಗ್ಬಿಟ್ಟಿದೆ. ಕೆಲವು ಸಲ ಬೈತಾರೆ, ಕೆಲವು ಸಲ ಬೆಡ್ಗಳ ಮಧ್ಯ ಮಲಗಿಸ್ತಾರೆ. ಈ ರೀತಿ ಅನುಭವಗಳು ಆದಾಗ ಯಾರು ತಾನೇ ಹೋಗ್ತಾರೆ ವಾಪಸ್ಸು? ನಾನು ಅಂಡ್ ದಟ್ಸ್ ದ ವಿಪರ್ಯಾಸ ನಮ್ಮ ದೇಶದಲ್ಲಿ. ಇವಾಗ ನಾನು ಖುದ್ದಾಗಿ ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ನಾನು ಸೇವೆ ಪಡ್ಕೋತಾ ಇಲ್ಲ, ಯಾಕಂದ್ರೆ ನನ್ನ ಹತ್ರ ದುಡ್ಡಿದೆ. ನನಗೆ ಬೇಕಾಗಿರುವಂತ ಒಂದು ಪ್ರೈವೇಟ್ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ನಾನು ಐ ವಿಲ್ ಗೆಟ್ ಮೈ ಕೇರ್. ಬಟ್ ದುಡ್ಡು ಇಲ್ದಿರೋರಿಗೆ ಯಾಕೆ ಗುಣಮಟ್ಟ ಬೇರೆ ಇರಬೇಕು? ಅವರ ಒಂದು ಮೆಟರ್ನಿಟಿ ಕೇರ್ ಯಾಕೆ ಬೇರೆ ರೀತಿ ಇರಬೇಕು? ಸೊ ಇದನ್ನ ನಾವು ಈ ಅನ್ಫೇರ್ ಡಿಫರೆನ್ಸಸ್ ನಾವು ಇಕ್ವಿಟಿ ಅಂತೀವಿ, ಅಂಡ್ ಇದನ್ನ ನಾವು ಅರ್ಜೆಂಟ್ ಆಗಿ ಫಿಕ್ಸ್ ಮಾಡಬೇಕು. ಇಟ್ ಕೆನಾಟ್ ಕಂಟಿನ್ಯೂ ಲೈಕ್ ದಿಸ್. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. ಇದನ್ನ ನಾನು ಸ್ಕಿಪ್ ಮಾಡ್ತೀನಿ ಸಮಯದ ಅಭಾವದಿಂದ. ಸೊ ಒಂದು ಕ್ವಿಕ್ ಪಾಯಿಂಟ್ ಇಲ್ಲಿ ಹೇಳಬೇಕಾಗಿದ್ದು ಅಂದ್ರೆ, ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ ಅಂದ್ರೆ ಅದು ಬೇರೆ ಎಲ್ಲ ಸಿಸ್ಟಮ್ ಮೇಲೂ ಅವಲಂಬನೆ ಆಗಿದೆ. ಫಾರ್ ಎಕ್ಸಾಂಪಲ್, ನಮ್ಮ ಅಂಗನವಾಡಿ ಕೇಂದ್ರಗಳು, ದೇ ಆರ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾರ್ನರ್ ಸ್ಟೋನ್ಸ್ ಆಫ್ ನ್ಯೂಟ್ರಿಷನ್. ನಮ್ಮ ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್, ದ ಅವೈಲಬಿಲಿಟಿ ಆಫ್ ಗುಡ್ ಕ್ವಾಲಿಟಿ ರೋಡ್ಸ್ ಅಂಡ್ ಪಬ್ಲಿಕ್ ಟ್ರಾನ್ಸ್ಪೋರ್ಟ್ ಇಸ್ ಅನ್ ಇಂಪಾರ್ಟೆಂಟ್ ಡಿಟರ್ಮಿನೆಂಟ್ ಆಫ್ ಹೆಲ್ತ್. ಅಂಡ್ ಸಿಮಿಲರ್ಲಿ ದಿ ಅಮೌಂಟ್ ಆಫ್ ಇಲ್ಲಿ ಬಲಗಡೆ ಕಮ್ಯುನಿಟಿ ಎಂಗೇಜ್ಮೆಂಟ್ ಅಂತ ಹಾಕಿದೀವಿ. ಸಮುದಾಯದ ಜೊತೆ ಸಮುದಾಯ ಸಂಘಟನೆ ಮತ್ತು ಸಮುದಾಯದ ಸಹಭಾಗಿತ್ವ ಇದು ತುಂಬಾ ಲ್ಯಾಕಿಂಗ್ ಇದೆ. ಅದೇ ಕಾರಣದಿಂದ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಸುಮಾರು ಆದಿವಾಸಿ ಸಮುದಾಯಗಳಲ್ಲಿ ನಾವು ವ್ಯಾಕ್ಸಿನ್ ಹೆಸಿಟೆನ್ಸಿ ಇದು ತೊಂದರೆನೂ ಇತ್ತೀಚೆಗೆ ಕಾಣ್ತಾ ಇದೀವಿ. ಕೊನೆ ಸ್ಲೈಡ್, ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. ಸೊ ಕೊನೆಯದಾಗಿ ದಿಸ್ ಇಸ್ ಸಾರಿ, ಯಾರು ಮ್ಯೂಟ್ ಮಾಡಿಬಿಟ್ರು, ನನ್ನ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿಕೊಂಡೆ. So at a slightly abstract level, I have identified a few things that are very important. So ನಾವು ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ಸ್ ಅಲ್ಲಿ ಸಿಸ್ಟಮ್ ಸಾಫ್ಟ್ವೇರ್ ಅಂತೀವಿ, ಆಟಿಟ್ಯೂಡ್ಸ್, ವ್ಯಾಲ್ಯೂಸ್, these kind of things, how do we build into our health workforce? Because the health workforce, ASHA agli, ANMs agli, doctors agli, how do we bring in an attitudinal change so that they feel more accountable to the population? Those kind of interventions are now extremely important. It's not only about placing a doctor, it's about placing a doctor who is happy and willing to do primary healthcare work. ಕೆಲವೇ ತಗೋತೀನಿ ಸಮಯದ ಅಭಾವದಿಂದ. 4ನೇ ಪಾಯಿಂಟ್, ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಾರ್ಡರ್. ತಮಿಳುನಾಡಲ್ಲಿ ಮತ್ತೆ ಹಿಮಾಚಲ್ ಪ್ರದೇಶಲ್ಲಿ ಸುಮಾರು ಸ್ಟೇಟ್ಸ್ ಅಲ್ಲಿ ಒಂದು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಾರ್ಡರ್ ಅನ್ನುವಂಥ ಒಂದು ರಿಫಾರ್ಮ್ ನ ಪಾಸ್ ಮಾಡಿದ್ದಾರೆ. ನಮ್ಮ ರಾಜ್ಯದಲ್ಲೂ 2001ನಲ್ಲಿ ಡಾಕ್ಟರ್ ಸುದರ್ಶನ್ ಅಂತ ಒಂದು ಟಾಸ್ಕ್ ಫೋರ್ಸ್ ಮಾಡಿದ್ದಾಗ ಅವರು ಫಸ್ಟ್ ಟೈಮ್ ರೆಕಮೆಂಡ್ ಮಾಡಿದ್ರು ಕರ್ನಾಟಕಕ್ಕೆ. 21 years it has still not happened. Niti Aayog in 2018 also put together a group to say how do we push states towards notifying a public health cadre. ಇದು ಇನ್ನೂ ಆಗಿಲ್ಲ. ಏನಿದು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಾರ್ಡರ್? ಸೊ ನಮ್ಮ ಡಿಸ್ಟ್ರಿಕ್ಟ್ಸ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್, ಇವಾಗ ನಾನು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಂತ ಹೇಳಿದ್ನಲ್ಲ, ದಟ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಇಸ್ ಆಲ್ಸೋ ಅಂಡರ್ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹೆಲ್ತ್ ಆಫೀಸರ್ ಅಂಡ್ ಪ್ರೋಗ್ರಾಮ್ ಆಫೀಸರ್ಸ್. ಸೊ ಈ ಎಲ್ಲಾ ಜಿಲ್ಲೆಗಳಲ್ಲಿ ಸ್ಪೆಷಲಿಸ್ಟ್ ಅನ್ನ ಸಡನ್ ಆಗಿ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹೆಲ್ತ್ ಆಫೀಸರ್ ಅಂತ ಪೋಸ್ಟ್ ಮಾಡ್ತಾರೆ. ಅವ್ರಿಗೆ ಯಾವುದೇ ರೀತಿಯ ಒಂದು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಟ್ರೈನಿಂಗ್ ಇರೋದಿಲ್ಲ. ಸೊ 25 ವರ್ಷ ENT ಸರ್ಜನ್ ಆಗಿರ್ತೀನಿ, ಸಡನ್ಲಿ ಐ ಬಿಕಮ್ ಅ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹೆಲ್ತ್ ಆಫೀಸರ್ ಇನ್ ಚಾಮರಾಜನಗರ್. ಹೌ ಕ್ಯಾನ್ ದಟ್ ಹ್ಯಾಪನ್? ಬಿಕಾಸ್ ನನಗೆ ಇಷ್ಟು 25 ವರ್ಷದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇರೋದು ENT ಸರ್ಜರಿ ಮಾಡೋದ್ರಲ್ಲಿ. ಇವಾಗ ಸಡನ್ ಆಗಿ ನೀವು ಈಕ್ವಿಟಿ ಆಗಿ ರಿಸೋರ್ಸಸ್ ಮಾಡಿ, ವ್ಯಾಕ್ಸಿನ್ ಹೆಸಿಟೆನ್ಸಿ ಅಡ್ರೆಸ್ ಮಾಡಿ, ಇಂಥದೆಲ್ಲ ನನಗೆ ಯಾರು ಟ್ರೈನ್ ಮಾಡಿದ್ರು, ಯಾರು ಹೇಳಿಕೊಟ್ರು? ಈ ಪ್ರಾಬ್ಲಮ್ನ ಇದು ಮಾಡೋದಕ್ಕೆ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಾರ್ಡ್ ಅಂತ ಸುಮಾರು ಜನ ನಾವು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅಲ್ಲಿ ಹೇಳ್ತಾ ಬಂದಿದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಗಿರಿಧರ್ ಬಾಬು ಅಂತ, ಡಾಕ್ಟರ್ ಸತ್ಯನಾರಾಯಣ್ ಅಂತ ಅವರು ರೆಕಮೆಂಡೇಶನ್ಸ್ ಕೊಟ್ಟಿದ್ದಾರೆ. ಆದ್ರೂ ಇದು ಆಗಿಲ್ಲ. ದೀಸ್ ಆರ್ ಇಂಪಾರ್ಟೆಂಟ್ ಸ್ಟ್ರಕ್ಚರಲ್ ರಿಫಾರ್ಮ್ಸ್ ದಟ್ ಆರ್ ನೀಡೆಡ್ ಇನ್ ಆರ್ಡರ್ ಟು ಮೀನಿಂಗ್ಫುಲಿ ರೆಸ್ಪಾಂಡ್ ಟು ದ ಪ್ಯಾಂಡಮಿಕ್. ನೆಕ್ಸ್ಟ್ ಪಾಯಿಂಟ್, ಕಲ್ಚರಲ್ ಸೇಫ್ಟಿ. ಇಲ್ಲಿ ಚಾಮರಾಜನಗರದಲ್ಲಿ ಟು ಅಡ್ರೆಸ್ ದ ಹ್ಯೂಜ್ ಮಿಸ್ಟ್ರಸ್ಟ್ ಅಮಂಗ್ ಆದಿವಾಸಿ ಕಮ್ಯುನಿಟೀಸ್, ನಾವು ಆದಿವಾಸಿ ಸ್ಪೆಸಿಫಿಕ್ ಕೋವಿಡ್ ಆರೈಕೆ ಕೇಂದ್ರ ಮಾಡಿದ್ವಿ. ಅದು ಮಾಡಿದ ತಕ್ಷಣ ಅವರ ಒಂದು ಪೋಡಲ್ಲೇ, ಅವರ ಒಂದು ವಿಲೇಜ್ ಅಲ್ಲೇ ಮಾಡಿದ್ವಿ. ಅದು ಮಾಡಿದ ತಕ್ಷಣ ಟೆಸ್ಟಿಂಗ್ಗೆ ಎಲ್ಲದಕ್ಕೂ ಮುಂದೆ ಬಂದ್ರು. ಸೊ ಇದು ಏನಂತೀವಿ ಅಂದ್ರೆ, ಪೀಪಲ್ ನೀಡ್ ಟು ಫೀಲ್ ಸೇಫ್ ಇನ್ ಹೆಲ್ತ್ ಸೆಂಟರ್ಸ್ ಅಂಡ್ ಹಾಸ್ಪಿಟಲ್ಸ್, ಅಂಡ್ ಸಮ್ ಆಫ್ ಇಟ್ ಇಸ್ ಆಲ್ಸೋ ರಿಲೇಟೆಡ್ ಟು ದೇರ್ ಓನ್ ಸೋಷಿಯಲ್ ಅಂಡ್ ಕಲ್ಚರಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್. Many, ನನಗಿಲ್ದಿರ್ಬೋದು, ಬಟ್ ಮೆನಿ ಪೀಪಲ್ ಫೀಲ್ ಡಿಸ್ಕ್ರಿಮಿನೇಟೆಡ್ ವೆನ್ ದೇ ಎಂಟರ್ ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ಸ್ ಆರ್ ಬಿಗ್ ಹಾಸ್ಪಿಟಲ್ಸ್. ಆ ರೀತಿಯ ಡಿಸ್ಕ್ರಿಮಿನೇಷನ್ ನಾವು ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕು. ವೈ ಡು ದೇ ಫೀಲ್ ಸೋ? ಅಂಡ್ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ನಮ್ಮ ಒಂದು ಸಿಬ್ಬಂದಿಗೆ ಟ್ರೈನಿಂಗ್ ಕೊಡಬೇಕಾಗತ್ತೆ. ಹೇಗೆ ಇದನ್ನ ಕಲ್ಚರಲಿ ಸೇಫ್ ಕೇರ್ನ ನಾವು ಹೇಗೆ ಪ್ರೊವೈಡ್ ಮಾಡೋದು. ಗುಣಮಟ್ಟದ ಬಗ್ಗೆ ಆಗ್ಲೇ ನಾನು ಮಾತಾಡಿದ್ದೀನಿ, ನ್ಯಾವಿಗೇಷನ್ ಬಗ್ಗೆನೂ ಮಾತಾಡಿದ್ದೀನಿ. ಸೊ ಈ ರೀತಿಯ ನಾವು ಯಾಕೆ ಇಂಥದನ್ನ ಹಾಕಿದ್ದೀನಿ ಅಂದ್ರೆ, ದೀಸ್ ಆರ್ ಥಿಂಗ್ಸ್ ದಟ್ ಗೆಟ್ ಲೆಫ್ಟ್ ಔಟ್. ನಾವು ದ ಈಸಿ ಪಾಲಿಸಿ ರಿಫಾರ್ಮ್ಸ್ ಆರ್ vacancies, appointing new buildings, etc. Before I complete, one caution is that social determinants jote now we are also talking of commercial determinants of health. So corporate industries are also determining people's health based on choices that they make. And given that this is a CSR linkage here, my submission is that wherever there is corporate engagement with the health system, we have to be aware of the fact that corporations also through their positions on especially pharma industry, food industry, and tobacco industry, ಬೇರೆ ಬೇರೆ ರೀತಿ ಅವನು ಪ್ರಭಾವ ಬೀಳಬಹುದು ಹೆಲ್ತ್ ಮೇಲೆ. ಸೊ ಆ ಒಂದು ಇಂಟ್ರೆಸ್ಟ್ ಅನ್ನು ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡು ಕೇರ್ಫುಲ್ ಆಗಿ ಎಂಗೇಜ್ ಆಗಬೇಕು ಅಂತ ನಾನು ಕೇಳ್ಕೊತೀನಿ. ನೆಕ್ಸ್ಟ್ ಲಾಸ್ಟ್ ಸ್ಲೈಡ್. ಸೊ I hope this kind of bilingual presentation try ಮಾಡಿದ್ದೀನಿ, ಸ್ವಲ್ಪ ಕನ್ನಡದಲ್ಲಿ ಸ್ವಲ್ಪ ಇಂಗ್ಲಿಷ್ ಅಲ್ಲಿ, and I hope this is useful and I hope the perspective is helpful in the conversation. I'm happy to give any clarifications moving forward.
Thanks, Prashanth. With your vast experience, I was a bit hesitant to force Prashanth. Like a couple of days back, madam, there was a big news in the media. These tribal people are ours to get into the vaccination. He disputed because right now he is with the tribal people. Even to waste his time, because he is involved in the vaccination. I was a bit hesitant. I was a bit, but in spite of all this, you made excellent presentation based on your grassroots experience. I think the 2 points are worth, repeating among several issues you have raised. One is the question of the inequality. India is a land of inequality. Inequality has got the very dimension. It need not be class-based, rich and poor. It's a caste-based, region, religion, gender. I think the various dimension of inequality, I think has its clear manifestation while we deal with the health issues. So you rightly pointed out, I think it should be taken care. More importantly, you have raised the issue of a advisory setup. COVID is not a small challenge on government. And a system, advisory system should be as robust as possible. So in our the first webinar, the recommendation, consensus, we have taken it to the government. It is not only medical professionals with the varied background within the medical professions. ಈಗ ತಾವು ಹೇಳಿದಂಗೆ ಬರೀ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟ್ ಮಾತ್ರ ಅಂತಲ್ಲ, ಬೇರೆ ಬೇರೆ ಡಿಸಿಪ್ಲಿನ್ ಜೊತೆಗೆ our candid recommendations are too. You should also have experts from other fields as related, because the COVID is not merely health issues, are much more than it's a livelihood issues for many people. So somebody from the economics, somebody from the education, somebody with the sociology, psychology, everything. You should have the advisory system consisting of the people expert from the diverse background. More importantly, advice system should be autonomous, independent, and empowered. I was in the government for a long time. An empowered body can do much more work effectively than an advisory body. This is very well taken, and thanks for your very important the point with sheerly from your experience. So ಈಗ ನಮ್ಮ ಜೊತೆಗೆ ಇನ್ನು ಹಲವಾರು ಪ್ರಮುಖರು ಜಾಯ್ನ್ ಆಗಿದ್ದಾರೆ. ಮೊದಲೇ ಹೇಳಿದಂಗೆ ಡಾಕ್ಟರ್ ಜಿ ಕೆ ವೆಂಕಟೇಶ್ ಇಸ್ ಎ ರಿನೌಂಡ್ ಯೂರೋಲಜಿಸ್ಟ್. ಡಾಕ್ಟರ್ ಕಟ್ಟಿಮನಿ, ಐ ಥಿಂಕ್ ಆಂಧ್ರದಲ್ಲಿ ಹಿ ಈಸ್ ಹೆಡಿಂಗ್ ದಿ ಟ್ರೈಬಲ್ ಯೂನಿವರ್ಸಿಟಿ ಇನ್ ಆಂಧ್ರ, ಸೆಂಟ್ರಲ್ ಯೂನಿವರ್ಸಿಟಿ, ಟ್ರೈಬಲ್ ಯೂನಿವರ್ಸಿಟಿ ಇದ್ದಾರೆ. ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್, ಎ ನ್ಯಾನೋ ಟೆಕ್ನಾಲಜಿಸ್ಟ್ ಫ್ರಮ್ ಇಂಡಿಯನ್ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಸೈನ್ಸ್, ರಿಟೈರ್ಡ್, ಆಲ್ಸೋ ಹಿಯರ್. ಎ ವೆರಿ ವೆಲ್ ನೋನ್ ಲಿಟರರಿ ಫಿಗರ್ ಸತ್ಯನಾರಾಯಣ ಇಸ್ ಆಲ್ಸೋ ಹಿಯರ್. ಇನ್ನು ಹಲವಾರು ಜನ ಜಾಯ್ನ್ ಆಗ್ತಾ ಇದ್ದಾರೆ. ಜಸ್ಟ್ ಟು ಗಿವ್ ಎನ್ ಐಡಿಯಾ, ದೋಸ್ ಹು ಸ್ಪೀಕ್, ದೋಸ್ ಹು ಮೇಕ್ ಪ್ರೆಸೆಂಟೇಷನ್, the very sage itself is from the multiple dimension, the experts from the various background. So now I shall call upon Shama Karakal. She is CEO Swasti Health Catalyst. I can be the perfect, in my opinion, perfect combination of the experience, the issues. She herself is deeply involved in the healthcare sector. It is for Shama Karakal.
Thank you very much, Dr. Prakash, and Yelrigu Namaskara. I think following Dr. Gupta and Dr. Prashanth is going to be a difficult job. Nonetheless, I'm a public health practitioner. I'm not a doctor, and I have not, like Prashanth was saying, I have not studied public health, but I have spent the last 20 years in public health in India as well as overseas. And what I'm going to actually, I think, end up repeating quite a bit of what Prashanth shared. Our ಹೇಳಿದೆಲ್ಲ ಸ್ವಲ್ಪ ಬೇರೆ ದೃಷ್ಟಿಕೋನದಿಂದ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತೀನಿ. ನಾವು ಸಾಕಷ್ಟು ಕರ್ನಾಟಕದಲ್ಲಿ ಮತ್ತೆ ಇಂಡಿಯಾದ ಬೇರೆ ರಾಜ್ಯಗಳಲ್ಲಿ ನಾವು ಕೆಲಸ ಮಾಡ್ತೀವಿ, ಡೈರೆಕ್ಟ್ಲಿ ಜನರ ಜೊತೆ ಕೆಲಸ ಮಾಡ್ತೀವಿ. and of different vulnerable populations. ನಾವು ಫೋಕಸ್ ಮಾಡುವಂತ ಜನ, ಪ್ರಶಾಂತ್ ಹೇಳಿದ್ರು, ಬಿಟ್ಟು ಹೋಗ್ತಾರೆ ಸಿಸ್ಟಮ್ಯಾಟಿಕ್ಲಿ. ಅಂತ ಜನರ ಜೊತೆಗೆ ನಾವು ಹೇಗೆ ಕೆಲಸ ಮಾಡಿ, ಹೌ ಡು ವಿ ಲುಕ್ ಎಟ್ ಅಚೀವಿಂಗ್ ಗುಡ್ ಹೆಲ್ತ್ ಅಂಡ್ ವೆಲ್ ಬೀಯಿಂಗ್ ಅಂತ ಇರುವಂತ ನನ್ನ ಸಂಸ್ಥೆಯ ಗುರಿ. So I think just going on to the presentation itself, and I'm going to see how this moves. I think 1 second. Yes. I am not sure why I am not able to move to the next slide. Naveen, is there okay, there I go. Sorry about that. So I think I'm looking at the journey of people currently in terms of healthcare, right? And usually we talk about subcenter, PHC, etc., but not looking at the system or the facilities. If you were to look at people, I think people start worrying about their health only when there is an unresolvable, serious, debilitating problem. ನಾನು ಮನೆಯಿಂದ ಎದ್ದು ಆಚೆ ಹೋಗಕ್ಕಾಗ್ಲಿಲ್ಲ, ಕೆಲಸ ಮಾಡೋಕ್ಕಾಗ್ಲಿಲ್ಲ ಅಂತ ಆವಾಗ್ಲೇನೆ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ಯೋಚನೆ ಬರೋದು. Until then, there is very little effort that is made in terms of health and preventive health. At that time also, can we self-medicate? ಎಷ್ಟು ಬೇಕಾಗಿದೆಯೋ, ಯಾರು ಹೇಳ್ತಾರೋ, ಅಕ್ಕಪಕ್ಕ ಯಾರಿದ್ದಾರೆ, ಅವರಿಂದ ನಾನು ಹೇಗೆ ಈ ಒಂದು ಕಂಡೀಷನ್ನ ಮ್ಯಾನೇಜ್ ಮಾಡ್ಬೋದು. ಅದು ಚಳಿ ಜ್ವರ ಇರಲಿ ಅಥವಾ ಹೊಟ್ಟೆ ನೋವು ಇರಲಿ, ಬೇರೆ ಏನಾದರೂ ಇರಲಿ. ಆಕ್ಚುಲಿ ಈವನ್ ಫಾರ್ orthopedic care, we see there is a preference for informal providers, right? unless surgery, major accident aito, allivargu, until it is seen as very big, access to care, the decision to look at which level of care to go is not about what is best for my health. It's about a lot of other things, which is where Prashanth was talking about social determinants and commercial determinants, right? I think for majority of us, and this is not just in rural, in urban also now, the focus is really on functionality and fixing symptoms, right? Which is why anything that is a quick fix, get me back to work anta iro anta ಒಂದು mentality ಇರೋದು, and solving the core problem is not really the issue, right? Prevention is definitely not on anyone's mind. And I think that is one of the biggest challenges that we have, and we have not sufficiently put in places systems to address prevention. It's often treat as is necessary when you can, where you can, right? And that is, I think, something that we have to recognize as the part of the journey. And I think this is something that Dr. Gupta mentioned in terms of financing. Prashanth also brought this up. I think financials, there is a whole dependency around incomes and how much resources you have, right? It is not uncommon. ನಮ್ಗೆಲ್ರಿಗೂ ಗೊತ್ತಿದೆ 20 ರೂಪಾಯಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಿ, ರೈಟ್? ಅದು ಹಳ್ಳಿಯಲ್ಲಿ ಇರಬಹುದು, ಪಟ್ಟಣದಲ್ಲಿ ಇರಬಹುದು, ನಮ್ಮ ಬೆಂಗಳೂರು ಅಂತ ಸಿಟಿಯಲ್ಲಿ ಇರಬಹುದು. ಐ ಥಿಂಕ್ what you have in your hand is money and resources, and that often determines your care as much as you can pay. So this is something that I think is very important to recognize when we're talking about rural healthcare and actually healthcare, primary healthcare overall. What does this lead to, right? What are the implications, right? Repeated episodes of the same condition, right? If you have diarrhea coming back repeatedly is not uncommon. Many of these conditions, whether it is chali, jwara, diarrhea, something else, has an impact on the body, has an impact on your resources. Kelsik hoglila antandre you don't earn. But the fact that it's repeated episodes is not something that we recognize, right? And that there is a problem we don't recognize. A lot of people living with undiagnosed chronic conditions, and then identifying them when they're serious, right? Timely care is a big challenge, and that's something that has already been discussed. I think poor quality treatment. This is something that I'm glad Prashanth brought out, but poor quality treatment, and there are some very stunning studies which I have recently seen during the course of the pandemic, that in India, informal care providers actually improve when you get better quality of care from informal providers than qualified providers. You know, it's very scary to actually understand that. So quality of treatment and that being poor actually leads to long-term issues which we don't recognize. And I think Dr. Gupta was talking about post-COVID issues. It's just an example of what is going to happen, right? And what we are actually having to deal with in the long term. The out-of-pocket expenditure, I don't need to talk about, very high in the Indian context. And I think the biggest challenge is that health and poverty is a cycle. We recognize it, but we are unable to break it. And poverty is definitely a cause of ill health. And then if you are sick, you are also going to become poor. So a vicious cycle. But like Prashanth was saying, what is the good news? There is good news, right? Technology, Dr. Gupta talked about this. There are all kinds of technologies, diagnostics, AI, mobile, medical devices. The last 15 years has seen, and actually the last 15 months, now sumar nodidivi, things that we did not think were possible are being possible today. So I think technology is a good news. I think nurses, and I will expand that now to say not just nurses, but paramedical teams, right, are better, willing, and available, and they're cheaper than doctors. Like Prashanth, and I'm glad Prashanth said this, but I have nothing against doctors, but I think we are overly focused on clinicians to look at primary healthcare. There is so much that can be done by a larger set of people. If we had better empowerment of our nurses and paramedical teams, I think we would be able to respond in a much better way. Primary healthcare actually reduces costs in the long term, right? Admission costs, timely care. We have data from around the world that shows that by at least 35%, if we invest in primary healthcare, overall costs can get reduced. And this is very, very important for a country like India. And we know that primary care, again, 90% of conditions can be better managed and treated at a primary care level if we put the right systems in place. And India has, there is a lot of innovation that's happened in India itself, but it's not just in India, it's across the globe. Good health and well-being, SDG 3 Anta, there is a lot of effort being made around the world. We have access to those lessons. Like Dr. Gupta was saying, if there is a village that is not doing well, is doing very well, it is possible to learn why it is doing very well. The question is, can we then apply the lessons, and is there a willingness to apply those lessons? I think medical science, social science, behavioral science, technology, it is not going to be about clinic, we are going to solve the problem of healthcare. And I think Prashanth couldn't have said it better. He said it very well. It is around governance. And I think those are going to be very, very key. This is something, I love this image, adike I'll share ಮಾಡ್ತಾ ಇರೋದು, because I think what goes into your health, and health ಅನ್ನೋ ತಕ್ಷಣ we talk about clinical care, right, or medical care. And if you see at the bottom, and this is a nice representation, which is why I like it, only about 20% overall of health is about health care, right? And there also it is about access quality. The remaining 80% is about health behaviors, the physical environment, socio-economic factors. And now ಇದನ್ನ completely primary healthcare ಬಗ್ಗೆ ಯೋಚನೆ ಮಾಡಬೇಕಾದ್ರೆ ಡಿಸ್ಕೌಂಟ್ ಮಾಡ್ತೀವಿ. Prashanth very nicely brought it in from a perspective of systems, right? But we have, and he said pretty much this is just slightly different framework, but workplace agilini, physical environment andaga, it need not be only factories and offices. We know today, for example, that ventilation bagge now eshtu COVID times al matadta idivi, in hindina probably 10-20 years al ventilation bagge ashtu matadilla, right? The same thing, even in homes, rural homes, ventilation is important, not just from a COVID perspective, but because of indoor air pollution and respiratory diseases. These connections we don't make, but I think are extremely important, right? And I think I'm actually going to wrap up. A lot of this has been said by Prashanth, reframing it here. One thing is, I think Department of Health and Family Welfare now government department responsible for health anta nodtivi. But to me, honestly, especially in rural areas, it cannot be only about health and family welfare, right? They may be responsible for the primary health care centers or the CHCs and the sub-centers or the district hospitals. But RDPR, WCD, Social Justice and Empowerment, Manrega anta now munche matadta idvi, SRLM, these agencies also have a role to play, because health is about the society we live in. It is not about who is delivering services. And for most of the government departments, I think the focus really needs to be on regulation and financing, because the kind of interventions that are needed, we need interventions that focus on prevention, community level interventions. I think Prashanth and Dr. Anil talked very nicely about, I call it SAF, so sanitation, air, water, and food. Or rather, I should say, we talk about it as SAF. SAF is sanitation, air, water, food, as well as the Indian systems of medicine, right? Health behavior, community level interventions, physical environment, socio-economic factors, idar mel focus madodu antandre, individually government departments find it very hard to do it. And that's where I think the meaningful engagement of private sector as well as civil society organizations is extremely necessary. In policy, we talk about it as Sarkar, Samaj, and Bazaar. And they can't work separately. They have to work together and play meaningful roles. I think the next piece is around quality of care and the outcomes. Now, usually inputs count ಮಾಡ್ತೀವಿ, outputs count ಮಾಡ್ತೀವಿ, ಎಷ್ಟು facility ಆಯ್ತು, ಎಷ್ಟು ಜನ ಬಂದ್ರು, ಎಷ್ಟು ಜನ ಹೋದ್ರು, but the outcomes now count ಮಾಡಲ್ಲ, right? And the quality of care is extremely important for outcomes. Therefore, capacity building, and again, very beautifully said by my two other co-panelists, it's not just about clinical teams in the public system. It has to be about families. It has to be about other partners, whether they're the panchayats, whether they're what should we say, livelihood teams, self-help groups. There are many on-ground points of contact for people, and has to be multidisciplinary. I think emotional health, mental health bagge now yeshtu charche ಮಾಡಿದೀವಿ, but that is not available, right? Domestic violence bagge now yaru matadalla, and I think Dr. Prakash talked about gender, whether it is violence against health workers, community health workers, ado Asha agirli, ANM agirli, or violence against clinicians, or violence against women and children inside the homes. Issues bagge matadala, but that is a big piece of healthcare, right? And is something that is visible, but that doesn't get addressed in the way that currently healthcare works. I think appropriate use of technology. I don't think technologies will solve everything. It's an enabler. We have a wonderful platform called eSanjeevani in Karnataka. But adu correct agi use agatta ilvo, and therefore what is a better use, and providing that flexibility in the kinds of technology that can be used. I think the last two pieces sort of touched by the other two speakers, but I think is very, very important. One, health and the concept ide. The concept of our soil and our environment being important for human health, right? Even though nutrition is poor is because the soil today is not as healthy as it was, say, 30 years ago. And if that soil is not good, we are not going to get nutrition. You and I may consume ragi, but a ragi today versus the ragi 30 years ago will be very different in its nutrient ability. So I think this whole idea of looking at working with people in the context that they're in, and how does it link up to our lives and our health, is very important. I think the other piece, which again during COVID times tumba charche aitu, energy in the context of improving health, right? And using renewable energy sources. So whether it is solar, wind, etc., very important. Prashanth touched on this briefly. Transportation is one of the biggest challenges, and one of the biggest factors for cost also in terms of care in rural areas. But transportation na solve marta illa, or we are not solving it smartly enough. And renewable energy is another way that we can look at solving for electricity availability in facilities, but also for people to actually get access to services in a way that they want access to services. I will stop with that and turn it over to, is that Pratap, Dr. Prakash?
Yeah. Thanks, Shamaji.
Sorry, one last thing. I think Mr. Suresh and others were asking. My email ID is on this last slide. And Dr. Prakash's email ID was also on his presentation. Now, presentations bekidre share martivi, and we would definitely welcome any questions post this webinar as well. Thank you so much.
Thanks, Shamaji. The whole webinar, is YouTube recorded. It will be available as done in the previous one. You have raised the range of issues. And the last one, the nutrition issue, and you quoted the example of ragi. Subsequently, Gayatri will speak and say, she is the strongest proponent of the millet-based food systems. Good thing you have raised various issues. All the three, the very learned persons who have made their presentations. It's the time to question, answers, and the reactions, not direct, unfortunately. We have the limitations. I think my good friend Pratap is working on it. I think he can place few questions on each or uncommon. So before that, I have one common observation. Looking into the presentation, we are discussing in the context of a certain possible third wave. Somebody has already predicted which could happen in a state like Karnataka. Number two, we are in the process of the vaccination. In my opinion, the dichotomy between urban and rural divide is very, very clear and apparent. Yeah, how do you address this issue? I think this please take this question from my end, either for rural Karnataka or rural India. It would make any difference at all. Where do you stand? What are preparedness? How to tackle that is an issue before. It's a specific context. I think that needs much more focus at present, while looking at the primary healthcare system, the rural Karnataka. Now I will hand over to Pratap Hegde to conduct the question and answer, the moderated question and answer. Pratap Hegde, please.
Yeah, good afternoon.
Before that, Madam Geetanjali can have a liberty to see that, what is the appropriate time, she can get into.
I would like to just say a few words now itself, because
excellent, madam, please.
First of all, I think it's been very enlightening to hear Professor Gupta, Prashanth, and of course my dear friend Shama speak on various aspects of public health and on the current status of the Indian healthcare delivery system. I think COVID has taught us a huge amount. It's actually not just shaken up India, but I think it's equally shaken up the advanced countries of the world. And while it's important for us to be self-critical, we must also observe and see that the so-called very robust healthcare delivery systems in the highly developed countries were also equally taken aback, equally shaken up, and equally, if I may say, if not more, unsuccessful in delivering appropriate care for COVID. It's only now, after 12 to 14 months, that you're seeing the advanced nations. In fact, Europe even today is unable to handle it. So India, with all its immense inequities, I think has done a reasonably good job. And there I would also like to give credit largely to the individual health workers. I have seen the way, I have experienced the way doctors and nurses, paramedical staff, and the private sector has risen to the occasion to work together and try and solve the problem. So I think but that also has brought out another thing. Our basic healthcare delivery mechanism has been very, very weak. So had it not been for the efforts of these individual doctors, individual nurses, individual large public sector, private sector enterprises, NGOs like Shama's, had it not been for the cohesive effort of these people, perhaps India would not have been able to deal with it, I would say, as well as it has dealt with it. So it has brought out a lot of, if our basic primary health delivery system had been robust, it's brought out the weaknesses and it's shaken up. I am seeing the government of Karnataka set up committees there. I am seeing even different state governments coming up and realizing that our health delivery system is so weak that if there's another pandemic, the economy and the country will just simply get wiped out. And you can't afford to do it. I mean, we know that India spends the lowest perhaps percentage of GDP on healthcare than most countries. Our spend is very, very low, and I'm told that the central government is reviewing that and would like to double that spend. As far as rural healthcare goes, yes, it's very, very difficult. For all the reasons that all of you have mentioned, it's very difficult. When the government of Karnataka set up this committee and I had a meeting with them, I said, if this is going to be just another committee, there'll be a lot of talk, a lot of presentation, but at the ground level, how are we going to attempt to implement, to make a change? We have to make a difference. We have to make a change, but how are we going to do it? Because right from the transport infrastructure, right from the quality of the healthcare delivery workers, the ASHA workers, as Professor Gupta mentioned, every aspect of the healthcare delivery mechanism is extremely weak. And how are we going to tackle it? The private sector has individually taken up and adopted villages and districts, like one of you said. We have done it, for example, Bidadi and all the neighboring areas, all the neighboring villages and districts have literally been adopted by the company. They've set up community health centers. We're monitoring them on a day-to-day basis, identifying healthcare indicators in that particular area and seeing how those indicators are incrementally improving on the various parameters of healthcare for that area every quarter, and trying to bring corrective action and improved healthcare delivery through the centers that we have set up. That's just we. Now, Bosch is also doing a huge amount of work on reskilling, for example. But here you need a very strong private-public partnership model to implement this change in a larger way, to scale up this change in a much larger way. And I think the Healthcare Committee Karnataka has set up attempts to bridge this gap and bring about a greater partnership. Now, private sector is very worried. You're speaking of PHCs in rural and district areas. Jindal Steel has set up a huge amount of PHCs in Bellary, and around 7 to 8. Now, once they set it up, the management of the PHC is with the government. And their complaint or their observation is that currently there is nobody manning those PHCs. Somebody mentioned about women care. They said there is not a single lady doctor because there is no place for them to stay or to live. So the government has now come up with a model for setting up new PHCs and to improve rural healthcare infrastructure. These new PHCs have got facilities for medical workers, etc. to stay. There is a training center there. There is also wellness and a yoga department. One of you mentioned there's a mental health care department. There's a separate child care and women care department. Now, how does one actually go and set it up? Because in spite of all that, there is a paucity of skilled manpower to man those units. And my recommendation to the government is, please first look at improving the quality and maintenance and delivery of the existing PHCs before you set up. Otherwise, you'll only multiply chaos and you'll have further medical and clinical inequities. So I am suggesting, start improvement of rural healthcare delivery in Karnataka. That will of course help you counter the third wave, but I think it's already, it's quite late for even the third wave, quite frankly. Now we'll have to just take the third wave management as a symptomatic. If there's a burst somewhere, go and handle it. Now we've learned more or less how to handle it. So we'll do it. But this will help us to prevent future pandemics because they're going to happen. The way the balance of the ecology and the environment is going, there are going to be many, many such viruses and bacteria that are going to develop in the world across the next decade or two. So at least we'll be prepared for that. And this is a very good way to improving the basic robustness of our existing healthcare, which is extremely poor, as you've all stated, and focus greater on public health. So what I would like to say here is that let us look at implementation of all the ideas and recommendations that have come up in the forum today. What I could help to do is to, if Shama can prepare a list of priorities that the state government can take up in its attempt, in its focus of this new drive for improving rural healthcare, because they've understood that. They've set up committees. There's a nodal committee at the ministry level, which has been set up, comprising of senior IAS officers. Shama's working with them on our new center, and they are going to work towards implementing this change in rural areas. So perhaps if I can get a list of priorities as to what exactly you believe should be done, how should the district prioritization be done? How should we implement? What should be the public-private partnership model? I'm working on it. Private sector is willing to invest, willing to spend, but they are saying, will the government run those? We'll just set up the structure, get a nice photograph in the newspaper, get our CSR budget paid for, but who's going to manage? Where are the doctors and nurses going to come? How are the ASHA workers who are already there going to be better equipped, as Professor Gupta rightly said? You see, so the actual implementation at the ground level of the attempt to bring change, we all identify the problem, but now how do we act on this to actually implement and to make a difference at the ground level? So I would like to suggest that the private sector, I know across the board, is doing a lot. They can do much more if the government partnership is assured, and if implementation is assured from the government through its newfound, prioritization of rural healthcare. So if I could get a list of priorities from you all based on the research and the actual, you have what I don't have. I can only say, and I can only coordinate, and I can only help get the funding and use my management expertise to make sure that it all works and happens at the ground level. But you have the understanding and the experience and the knowledge of the ground reality. So if I can get a list of priorities, what should this healthcare CSR rural expansion of infrastructure committee do in order to actually make a difference? Can we just take up 2 districts? Because I've learned that if you take up small objectives, small but measurable improvements, if you can show, then it is much easier to scale up after that. That is my only submission, because I'm really keen that we implement and show a change. It may be just 2 villages, it may be just 1 district, but how do we do it? What are the areas we work with the government to prioritize?
Excellent, madam. Yeah, definitely Shama could help, and we all, from the different fields, we can definitely help to see that, this webinar will never end in itself. It will come out with some sensible suggestion. As in our first webinar, we could come out with several suggestions, which the government, we have forwarded to the government. The government took note of that one. Definitely, I think the expectation is much more than, it's really appreciable, being in your capacity as one of the advisors to the government. You are very candid to say that, something could emerge, we can place before the government. And also it's music to ear of people like us, how you have pointed out, the imbalance between ecology and economy, and let us be prepared to see that if it continues, many more pandemics in the future. Really, it's appreciable to see that you have pointed, you have noticed, and you are on it. Thanks, madam. Definitely, we'll come out with some sensible suggestions so that you can take before the government. Pratap, are you ready with a set of?
Yes, of course, I can start. Yeah, I will finish this in the next 10 to 12 minutes. Good afternoon to everybody. My name is Pratap Hegde. The first question, which came from few people, and I'm just trying to curate the questions and ask. This is talking about our traditional models which have been neglected, like we talked about midwife, Ayurveda. Now questions are, what else? Can someone, maybe I think this question is to both Prashanth and Shama. What are the other traditional practices which can be considered for this, and how can we take this forward? Can there be some kind of movement around this, so that this could be a very, very important dimension, particularly considering healthcare rather than disease care? Any of you? I think this could be Shama or Prashanth.
I think Prashanth can come in first. He's in a poorer network area.
Sure. Thanks, Shama. I think this is extremely important because reliance on traditional medicine is not only about the fact that it is accessible and cheap, but it is also because it is socially and culturally much more preferred. But we have to be careful, because on the other hand, traditional medicine, building systems relying on traditional medicine also have to do about encouraging scientific temper. There is a whole movement in modern medicine called evidence-based medicine on one hand. So I think we must distinguish between what people do at homes as a first point of call. Negdi bandaga, we have our own ways, with turmeric, pepper, etc., honey, we make at home. That is one thing. Organized traditional medicine and business houses today, which have also made a market, which have seen the market of traditional medicine and also distort priorities there. I make a distinction between the two. We must go for the former. It's not about, because institutionalized Ayurveda can be as bad as institutionalized modern medicine. We know the ills of the modern pharmaceutical industry have perpetrated on doctors and health systems. The same thing can also happen through institutionalized, corporatized Ayurveda. So when I am saying traditional medicine, my submission is that we must try in a decentralized way to document local traditional practices and respectfully suggest them in primary health centers, having home herbal gardens, for example. There are so many herbs, Vasaka, Tulasi, etc. These are small-scale, home-based traditional medical practices that I would offer to strengthen. Sorry, just one other point, because this it's also important that over-reliance on over-medicalization is also a big problem that this will solve. Because like I said, on one hand, we make people feel vulnerable if we continue this assault on calling some practices as superstitious and foolish, etc. But on the other hand, we must build the capacity to recognize when something cannot be solved at homes. There are several complex fractures that people try to treat through traditional bone setters. That is dangerous. That can result in harm. So we must try and encourage a system where we respectfully engage with traditional healthcare providers, and they can refer people to the formal health system if and when need be.
Thank you, Prashanth. I think I would move to the next question.
I think Professor Gupta also can respond to this question.
I have another question for him. Maybe he can join.
Even on the traditional knowledge, Dr. Sudarshan in the BR Hills, Solega tribals, he worked for 25-30 years with Solega tribals and discovered, which is also evident in other parts of the country, that women, when they deliver a child, they sit in a squatting position. Look at the delivery table of all the hospitals, the modern hospitals. They are horizontal, a very uncomfortable position for women to deliver a child. And this is a tyranny of a wrong design imposed by the whichever Western scholars and doctors and policymakers, and we continue to follow it. Dr. Sudarshan has been talking about it for at least 3 decades. No improvement. Forget about the rest of the country, even Karnataka. No change in the delivery models. So this is just one example. Another example, in Champaran, we met a midwife during our Shodhyatra. We were sitting in a school compound and she was very angry. And she said, look at the children which I have delivered. None of them have specs. And most of you have specs. So I said, what mistake is being done? She said, you know what? Infant, in the fetus is in the womb for 9 months in the dark environment. You do the delivery in a lighted environment. There's a shock to the child. Her eyes get strained and she becomes a bit fearful. You don't want a child to enter the world with a fear. You should deliver the children in a very mildly lighted room. And the umbilical cord should not be cut till it is pulsating for about 8 to 10 minutes. Now, these are advice followed from a midwife, which scientifically are valid and must be established, must be accepted. But no, we would not. So there are a large number of such examples. We will not take too much time on that. But I would suggest that these are areas of science. There's nothing like, you're not being condescending, you're not being patronizing to people by accepting good science. Good science by anybody must be accepted. And I think in this case, because the Solega tribals in Bihar Hills and the midwife in Champaran, if they have a good practice, follow it. What is the problem with that?
Thank you, Dr. Gupta. I think, Professor Gupta, I have one more question to you. You talked about linking PHCs and startups. It's a very fascinating idea. But someone in the audience has specifically asked, what are the risks in it? Like what kind of risk management consideration we should have when we open up that particular opportunity for the business sector to try out various new devices with the people and the risks associated with that.
You see, first of all, let us accept that even a knife is a risky device. Knife can be used to cut vegetable and knife can cut the body. So risk is an inherent part of our life. And every day we take reasonable risk, and we have to make the risks explicit and upfront. That is what a responsibility of a good doctor, good scientist, good startup is, that you must share all the risk upfront so that people who have to participate know what the risks are. When the so-called new home kit for antigen test was advertised on the full page of Times of India, no risk was mentioned that if you did the test yourself, this test has 70% chances of, the negative report has a 70% chance of being wrong, and therefore you must do RT-PCR if you are wanted to be more sure. This was not mentioned. So risk must be mentioned, and I have full agreement with that. But please remember, startups normally will go to user trial after regulatory approval, not before regulatory approval. So far as the regulatory approvals and regulatory risks are there, then the ethics committee will be involved. Ethics committee will oversee. Whenever you do trial with human subjects, ethics committee has to be involved in the concerned organization. And I would suggest that district hospitals or the state hospitals, private as well as public, should create ethics committees to help these startups who are not affiliated with any institution to get all the precautions and prior informed consent on video, because many of the people are illiterate, and then do these trials. The question is, today, all the new advancements that are taking place by our young entrepreneurs for health and diagnostics and care are not reaching rural areas because there is no supply chain. There is no supply line for that. Most of these are concentrated in urban areas. We need to change this, and we need to make a quantum jump. We will not go step by step. We will take the latest to the neediest most. The most needy should get the latest solutions that we have. Now, there's a person in Bhubaneswar who has developed a 30 rupees test for 5 blood tests. Quickly he can get. There's another startup who has got in 250 rupees, 30 tests. Now, all of these cost a great deal when you go to pathology lab, which is in a city nearby, maybe 60 kilometers away from a village. Whereas you can now do these tests in the village itself with a reliability of very high order. So why won't we equip the health workers with a small incentive to charge a small amount of money as a service fee to augment their little income and maintain the equipment and provide these services? We need to modernize our health workers and their toolbox for providing high quality care to our people, thanks to this very robust startup ecosystem that we have.
Thank you, Professor. I think the next question, perhaps this is better answered by Mrs. Gitanjali Kirloskar. This is one question came, there could be conflict of interest between corporates and public healthcare, particularly when it comes to primary healthcare, etc. Now, what are your thoughts on how do we manage this potential conflicts which could be arising in this kind of working together situation, which is very critical, everyone agrees on?
Ms. Gitanjali has, I think, disconnected. I think Shama can, Shamaji can answer.
Shama, you can answer this, yeah.
So I'm not speaking on behalf of Ms. Kirloskar. I had raised my hand on the previous question around risk, and I agree with what Dr. Gupta has said. And of course, Prashanth has also responded. Whether it is risk or it is conflict, I think it is bound to be there given the kind of intersectional work that is required, right? Even within civil society, just within government or within private sector, also there is risk and conflict. So when we are talking about between sectors, there is likely to be more of it. But to my mind, shying away does not help, right? I think how do we look at governance is something that Prashanth talked about. I think we don't do enough focused work on what does governance mean. So number one, I would say governance is extremely important. That decentralized governance even more so, right? We can have a committee at a panchayat level, but are they equipped, empowered to actually make decisions? And are they truly decentralized? So I think the whole piece around governance, number one. I think on conflict, just like we disclose risk, we must identify it, we must disclose it, we must plan for it, and say when it occurs, and whoever calls it out, and anybody must be able to call that out, how do we resolve it? And I think these mechanisms exist. We have not functioned as a society for so many millennia without having mechanisms. I think we can address them, solve them. But are we willing to put in the effort, the investment, like Prashanth says on his chat message, to actually get into all of these? And this is really where I think we don't do enough, right? This is the hard work. Finding
I have one more question to you. Perhaps you can answer. You know, there was an issue which came up about the trust deficit between the poor and the corporate. I mean, the healthcare or the government or whatever. And it could be spilling over to the vaccination or, Adivasis not coming up, some of those issues. What are your specific thoughts about how to tackle this particular challenge?
And I'm also reading the chat, right? So I think one of the biggest things is that we do not have community or citizen engagement sufficiently in all of these mechanisms and processes. We are not transparent. We believe people are only beneficiaries. I think we have to, that is a huge shift we have to make. People, and that is actually the vision in the Alma Ata and even in the Astana Declaration that we have signed up to, that it is community empowered, community led primary healthcare. But where are the people? How often are we bringing citizens to the table, and those citizens, whether in Adivasi communities or tribal community, rural communities or urban communities, are at the table providing their input on saying, yes, I agree to this, and no, I want it done this way. And I think often that is where, I mean, and to Dr. Suresh's point, right, the system of politics and business and bureaucracy, and I think like Prashanth said, because we don't have people asking these questions, we're not as people demanding accountability, is that a lot of these things come and will get hushed up, or you will have these problems that get arisen. I think one of the things I want to bring up is the ethics of public health. And there are ethics in every subject, right? But I think we are talking about where is the ethics issue getting discussed and understood, right? Decisions get taken and get announced without sufficient consideration of some of these things. And that is honestly where I think the problem is. In my own work, right? Where we have actually said we will not do certain things, because when we had the conversation with people, the public spaces, people coming in, and they said, we don't want it like this.
Sure.
Now, when people don't want it, how do you change it? I think we have to be willing to do that, right?
Yeah. In the interest of time, I will move to the next. Thank you so much, Shama. I think it has been a good, enlightening discussion. And this question is to Professor Gupta. This is Manrega. Particularly, you talked about Manrega and utilization of this particular scheme for public health care, particularly primary health care. And can you little bit more specific about what exactly is the gap right now and what need to be done to get going on those initiatives, which can be really started quickly, using this whole scheme and the funds and the capabilities available there?
So let me state again, there's a provision that 100 days of employment has to be provided within 5 kilometers of the region where people demand job. This is what the law says. And our average days of provision is about 45 to 50. Very rarely have we provided more than 50 days. So there is an unmet potential. Resources are available, which can be used. During Dr. Kalam's time, I had requested him to write to the government that not only the menial work, but also mental work should be included in the Manrega. So first point is, can we include work which involves processing of information? For example, mapping the experience of healthy people in the community and healthy neighborhoods and healthy communities. Now people will go document, those who are literate will document, write down what is the food they eat, what is the daily lifestyle they follow, and are their animals also healthy just as they are healthy, so that one health concept can also be brought in. And then they can also document the traditional health practices which have kept them healthy. So the wisdom of the healthy people and healthy communities will be documented so that the other regions within the village and other villages can benefit. This is one task. The second task that Manrega can include is hygiene and waste management, bio-waste management, as well as the COVID waste management in a manner that is compatible with the best ethical and hygiene practices, which means that you will have tools to process and use that material. Now, some communities have converted PPE into tiles, into bricks, and such other activities. So they can convert the plastic waste into some useful building material, which can then be used for pavement of the roads or tiles or footpath, or even used for construction. That means it can also generate economic activity. Third thing, which is very important, is mapping of the environment, encroachment on the common lands, water bodies, all of which is linked to the drainage and the health system of the village. Common properties are useful not just for animals, but for everybody, because that is where the communities are created. When you have common facilities, people come together, and that's how the communities are created. More and more privatization, more and more individualization of the facilities sometimes is necessary, but not always. Certain things must happen in common, and certain things will have to happen. Drainage cannot be done by individually. Everybody will have to put joint hand in drainage. So to ensure that the dengue and the malaria and the other problems can also be controlled, you must have read recently that China controlled the malaria completely. Now we can also control malaria by having proper drainage. We have not paid attention. Dr. K.M. Munshi in 1952 had delivered a lecture on Gospel of Dirty Hand and talked about the need for drainage in every single village. We have not done that properly. So wherever necessary and wherever needed, Manrega can be used for drainage system and waste management system. Finally, I would say that Manrega should also be used for public awareness about the health issues. So when they are organized for work, they should also be organized for camps, for various minimum preventive health practices. They should be given soaps along with the payment of wages, so that in conventional terms, many times people wash their hands with soil or with clay and with ash and all of that. But maybe if soap is most necessary, particularly from the COVID point of view, then they better use soap. And if they can get a soap along with the work, that will be even better. Their habits will change. We should also ensure that Manrega people are involved in improving the environment of school building, primary health center, growing medicinal plant in school, medicinal plant in primary health center. Tulsi can be planted everywhere. Adusa can be planted everywhere. Curry patta can be planted everywhere. You know, there's some common plant which provides so much nutrition to the people, and they're very important part of our. Everybody should begin with the Tulsi tea and ginger tea. So I think Manrega can be a powerful mobilizer, mapper, and disseminator.
Thank you, Professor. I think very, very specific and very, very useful, enlightening answer for that. And I think with this, I would hand over to.
Thank you. ಈಗ ಬಹಳ ಮುಖ್ಯವಾದ
shortage of time.
ಬಹಳ ಮುಖ್ಯವಾದಂತ ಇಬ್ರು ಆಮೇಲೆ ಗ್ರಾಮೀಣ ವಲಯದಿಂದ ಬಂದಿರತಕ್ಕಂತ ರೆಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಕ್ಕಂಥ 3 ಮಾತಾಡ್ತಾರೆ. ಈಗ ಪ್ರೊಫೆಸರ್ ಗುಪ್ತಾ ಅವರು ಒಂದು ಕಿವೇಟ್ ಹಾಕಿದ್ರು, ಈ ಚರ್ಚೆ ಇಲ್ಲಿಗೆ ನಿಲ್ಲಕೂಡ್ದು ಅಂತ. ಅದನ್ನ ಮೇಡಮ್ ಗೀತಾಂಜಲಿ ಅವರು ಹೇಳಿದ್ರು, ಐ ನೀಡ್ ವೆರಿ ಸ್ಪೆಸಿಫಿಕ್ ಸಜೆಷನ್ ಟು ಸಿ ದಟ್ ಇಟ್ ವಿಲ್ ರೀಚ್ ದಿ ಗವರ್ಮೆಂಟ್. ಅಂಡ್ ಈಗ ನಮ್ಮಲ್ಲಿ ಚರ್ಚೆಗೆ ಸಮಯ ಇಲ್ಲ, ಯಾಕಂದ್ರೆ ಕೋವಿಡ್ ಇಟ್ ಡೋಂಟ್ ಗಿವ್ ಎನಿ ಟೈಮ್ ಅಟ್ ಆಲ್. ಸೊ ಇದನ್ನ ಸರ್ಕಾರದ ಮುಂದೆ ಯಾವ ರೀತಿ ತಗೊಂಡು ಹೋಗ್ಬೋದು, ಯಾವ ರೀತಿ ಅದನ್ನ ಅನುಷ್ಠಾನಕ್ಕೆ ಬರ್ಬೋದು ಅನ್ನೋ ವಿಚಾರದಲ್ಲಿ ಇಬ್ರು ನಾವು ಎಕ್ಸ್ಪೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಒಂದು ಗಣೇಶ್ ಕಾರ್ನಿಕ್ ಅವರು ಈ ಸರ್ಕಾರದ ಜೊತೆಗೆ ಉತ್ತಮ ಬಾಂಧವ್ಯ ಇದೆ, ಅವರಿಗೆ ಆರೋಗ್ಯ ಮಂತ್ರಿಗಳು ಚೆನ್ನಾಗಿ ಗೊತ್ತಿದೆ ಅಂತ ಹೇಳಿದ್ರು. ಅವ್ರು ಏನ್ ಮಾತಾಡಬೇಕು ಅದ್ರ ಜೊತೆಗೆ ಈ ವಿಚಾರನು ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡಿರ್ಲಿ. ಆಮೇಲೆ ನಮ್ಮ ಸುದರ್ಶನ್ ಅವರು ವಿರೋಧ ಪಕ್ಷದ ಒಂದು ಹಿನ್ನೆಲೆಯಿಂದ, ಇಲ್ಲಿ ಪರ ವಿರೋಧ ಅಂತ ಪ್ರಶ್ನೆ ಇಲ್ಲ, ಒಟ್ಟಾರೆ ನಾವು ಕೋವಿಡ್ ಜಯಿಸ್ಬೇಕು. ಈಗ ನಾನು ಶಲೈ ರಿಕ್ವೆಸ್ಟ್ ಗಣೇಶ್ ಕಾರ್ನಿಕ್ ಅವರಿಗೆ, ಗಣೇಶ್ ಕಾರ್ನಿಕ್ ಅವರು ಇದ್ರಲ್ಲ?
Yes, I can. Can you hear me?
ಆಗುತ್ತೆ, ಪ್ಲೀಸ್.
Okay, fine. ಮಾನ್ಯ ಪ್ರಕಾಶ್ ಕಮ್ಮರಡಿ ಅವರೇ, ಸನ್ಮಾನ್ಯ ಸುದರ್ಶನ್ ಅವರೇ, ಕೊಬ್ರೂರು ಶಾಂತಕುಮಾರ್ ಅವರೇ, ಅದೇ ರೀತಿ ಇವತ್ತು ಪ್ಯಾನಲ್ ಡಿಸ್ಕಷನ್ ಭಾಗವಹಿಸಿದಂತ ಸನ್ಮಾನ್ಯ ಅನಿಲ್ ಗುಪ್ತಾ ಅವರೇ, ಶಮಾ ಕಾರಕಲ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಪ್ರಶಾಂತ್ ಅವರೇ ಮತ್ತು ಇತರ ಎಲ್ಲ ಆತ್ಮೀಯ ಬಂಧುಗಳೇ, I would like to say a few things in Kannada and few things in English. I must thank Dr. Kammaradi for organizing this very insightful, thought-provoking, and a scholarly kind of a discussion with a larger perspective on managing the healthcare in the entire country as well as in Karnataka state. ನಾನು ಇಷ್ಟೇ ಹೇಳಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತೇನೆ, ಬಹಳ ಸಮಯ ಇಲ್ಲ ಅಂತ ಹೇಳಿ ಪ್ರತಾಪ್ ಹೇಳಿರೋದ್ರಿಂದ. What I suggest is, this is more of an academic discussion. ನಮ್ಮ ಮುಂದೆ ಪ್ಯಾಂಡಮಿಕ್ ಇದೆ. ಇವಾಗ ನಮ್ಮ ದೇಶದಲ್ಲಿ, ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ we have established a certain medical infrastructure. ಅದರ ಕೊರತೆಗಳಿದೆ, ಅದರಲ್ಲಿ ಅಡ್ವಾಂಟೇಜಸ್ ಇದೆ, ಅದರಲ್ಲಿ ಪ್ಲಸ್ ಪಾಯಿಂಟ್ಸ್ ಇದೆ, ಮೈನಸ್ ಪಾಯಿಂಟ್ಸ್ ಇದೆ. ಆಶಾ ಕಾರ್ಯಕರ್ತರಿದ್ದಾರೆ, they are not empowered, they are not properly skilled, but we have a certain system. Now, what is the short-term immediate requirements to ensure that the existing medical infrastructure that we have in our state addresses the issues of pandemic as well as other health issues? And the second part is, what is long-term policy initiative that has to be taken up? This is one part which I wanted to request the scholarly panel members to draft certain bullet points, short-term, long-term. One part. Second thing is, in the entire discussion, we never try to touch upon the availability of private practitioners. Since they are a huge human resource, quality human resource, how do we make use of the existing private practitioners, starting from grassroots level to whatever level you can envisage? And the third, when I say private practitioners, I include traditional medical practices like medical systems like Ayurveda, Unani, Siddha, homeopathy, naturopathy, and all kinds of the system that we have. How do we incorporate them into the system to ensure that the rural masses at the grassroots level get better medical health care? The third most important issue is, ultimately it is the money, it is the resources. So people can recommend, but the government, successive governments have had their own problems with regard to going for better fund allocation for healthcare sector. Pandemic has come as a kind of blessing in disguise, that we are addressing the public health issue from a different perspective. So what I would like to suggest is, considering these points, can we make a small presentation to the concerned health minister or to the chief minister. I will also request Sri Sudarshan ji to possibly assist me in this. In a short, kind of a presentation, we can approach the government, we can approach the chief minister, which I will try to facilitate, because the entire discussion, especially what Professor Gupta mentioned and what Mr. Prashanth was mentioning with his rich experience from his, workplace in Bilagiri Ranganbetta, I think this is something we all should consider seriously to incorporate into our public health policy of the government. I can become the facilitator to see that this reaches the government at the right time and certain initiatives can be taken. The last point is long-term strategies. For example, the medical colleges, the private medical colleges, the private medical establishments. And then, during the discussion, as it was pointed out, and Dr. Anil Gupta was very candid about it. The practices that are traditional, but which contained tremendous amount of science behind it. The delivery poster he mentioned about, it was kind of mind-boggling. I never thought about it. We didn't know about it. So if there can be some organizational effort to understand the healthy practices practiced in this country in a traditional way and the science behind it. This needs to be researched, this needs to be documented, this needs to be standardized. We can have similar health practices spread over the entire country, region specific and area specific, and community specific. So these practices can be, kind of documented, researched, and recorded for the welfare of the entire mankind as such. So this particular seminar has thrown light into many areas. I don't think, Mr. Prakash, we can summarize into some, a small compendium and then say this is what we have done. But like I said, like I requested, what is that we should do immediately? We can have bullet points so that we can go and talk to the people concerned. What needs to be done long term in terms of medical education, in terms of the curriculum, in terms of the other parallel medical systems and all those things. So this seminar can be an initiative for reaching out to the policymakers as well as the government and the health department. We can look at it from that perspective. Me and Mr. Sudarshan, we can only act as facilitators, but I must thank you for enlightening all of us. And lastly, since Mr. Shantkumar represents the farming community actually may contribute, because there are a lot of such traditional practices which we follow even without somebody recommending it to us. Like you go to any rural household, they have different kinds of systems of looking after their own healthcare. So possibly he can contribute after the discussion. So if you permit me, since you said it is 3 to 5, I have tied up with some other engagement. So I only request you, let's have a kind of synopsis drawn of this discussion for short term and long term. And I promise you, 2, 3, 4 of us can go to the health minister, we can go to the chief minister, we can talk to the secretary, medical education and health. Let's see what best can be done. This is all what I wanted to say. And I thank you for this wonderful opportunity. And I think we need to have some more deliberations, more serious seminars on different topics that you have touched upon. Especially listening to Dr. Prashanth has been an eye-opener, because he has done lots of work in the area of public health, which has to evolve itself as a major faculty in our universities. So I think there are many such faculties which have been identified in this discussion, which needs to be addressed individually. It can be nutrition, it can be rural healthcare, it can be alternative system of medicine, it can be public health. There are many such issues. Empowering the Asha Karyakartas or grassroots level public health workers, empowering them with technology. There are a lot of issues which have come out. So I don't think we can address all at one time. Immediately, if you can have certain things listed out as bullet points, which can be taken up immediately, especially from the point of view of facing the third wave that is being discussed about. I'm very open, and I'm at your service. You can always use me, and I promise you, I will definitely arrange a meeting with the Chief Minister and the Health Minister, as well as senior bureaucrats in this regard. Thank you for this wonderful opportunity.
Thanks, Ganesh ji. Yeah, excellent. Let me assure you at this point, as we have done in our previous webinar, definitely we will come out with the key issues which have emerged in the discussed, and also some doable. I'm a little more careful because I was part of the government for quite a long time. So government in a normal time also is not in a position to take up all suggestions. What can be doable, definitely we'll come out with. Shamaji also can help us, and your assurance that it will be taken to the government chief minister is the most welcome one. Definitely we'll do as soon as possible. Thanks a lot. And now I think also your assurance, you take forward with forgetting the difference within the politics, you can take together. It's the most reassuring for us. Iga Sudarshan ಅವರು ಮಾತ್ರ ಒಂದು 2 ನಿಮಿಷ ಕೇಳಲಿಕ್ಕೆ ಆಗಲ್ಲ ತಮಗೆ? ಏನೊಂದು 5 ನಿಮಿಷ.
Yeah, I'll stay put. He's a senior colleague and I have a lot of respect and regard for him. I would definitely like to listen to him.
Sudarshan 20 ನಿಮಿಷ ಮೊದಲೇ ಬಂದ್ಬಿಟ್ಟಿದ್ದಾರೆ ಅವರು. I really appreciate. Sudarshan, ಈಗ can you come to picture now? Sudarshan, I think video our Kolarದಿಂದ
Prakash, if you can tell Prakash, 1 ನಿಮಿಷ.
ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಸುದರ್ಶನ್
ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಪ್ರಕಾಶ್
ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಒಂದ್ ನಿಮಿಷ ಗಣೇಶ್ ಅವರನ್ನ ಹೇಳ್ತಾರೆ. ಗಣೇಶ್ ಹೇಳಿ. ಗಣೇಶ್,
I wanted to meet Dr. Prashanth and Dr. Gupta and Shama Karakal. Just wanted to interact with them one-to-one, maybe at a later stage. So I just wanted to communicate to them through you, if you permit me subsequently.
Definitely, there is.
Okay, fine. Okay, thank you.
ಈಗ ಸುದರ್ಶನ್ ಅವರು.
ಸೊ ಪ್ರಕಾಶ್ ಅವರೇ ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಕೇಳಿಸ್ತಾರೆ. ಪ್ಲೀಸ್ ಗೋ ಹೆಡ್.
ಹಲೋ,
ಕೇಳಿಸ್ತಾ ಇದೆ ಸುದರ್ಶನ್?
ನಮಸ್ಕಾರ ಎಲ್ಲರಿಗೂನುವೆ. My sincere appreciation to Shri Prakash for organizing this meeting. Meeting went on well and very useful points are there, especially submission made by Dr. Anil Gupta, Srimati Shama, Dr. Prashanth, and as chief guest Srimati Geetanjali Kirloskar and other friends, especially my colleague Shri Ganesh Karnik. They submitted a very useful points to strengthen the rural health system in Karnataka. See, one thing I would like to draw your attention: Corporate Social Responsibility Act, right to education, then right to food, right to work, and Manrega. These are very progressive acts which are introduced by Dr. Manmohan Singh during UPA rule. Then I appeal to the present government of India and the Parliament to pass a Health Security Act, which are very useful to especially to the common man, because it's a constitutional right. Right to live and right to health is our constitutional right. So I appeal to the government of India to introduce Health Act across the country in consultation with all the chief ministers and in consultation with all the members of Parliament, which are very useful and need of the hour. So there is an urgency to reform, modernize, and to decentralize the health system in Karnataka. Basically, Karnataka is hub of medical education and also medical tourism. So when compared to other states, we are ahead of it in health system. So then one thing I would like to suggest, this MBBS doctors, this 5 years of service, it should be made compulsory in rural areas, and also introduction of this BSc degree course, especially in related to public health system, which are very useful in rural areas. I think it's a policy matter, because policy matter and acts are the role and responsibility of the government of India. The government of India has to consider these aspects to improve, to strengthen the
rural health education and health system of the country. And one thing na ಏನು ಹೇಳ್ತೇನೆ ಅಂತ ಹೇಳಿದ್ರೆ, ಒಂದು ಗಣೇಶ್ ಕಾರ್ಣಿಕ್ ಅವ್ರು ಹೇಳಿದಾಗೇನೆ ನಾವೊಂದು ಡೆಲಿಗೇಷನ್ ಹೋಗೋಣ. Let us submit our proposals and prepare one good note to the Honorable Chief Minister and to the Health Minister. ಈ ಬರೋ ದಿವಸಗಳಲ್ಲಿ ಅದು ಕೂಡ ತುಂಬಾ ಯೂಸ್ಫುಲ್ ಆಗುತ್ತೆ. ನಮ್ಮ ಕರ್ನಾಟಕದ ರೂರಲ್ ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ ಅನ್ನ, ಕಾಮನ್ ಮ್ಯಾನ್ ಅನ್ನ ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡು ಆ ಕೆಲಸವನ್ನು ಕೂಡ ಮಾಡಬೇಕು. ಅಂಡ್ ಆಲ್ಸೋ ಬ್ರಿಂಗಿಂಗ್ awareness among the people is very, very important, especially self-care medication ಅಲ್ಲ, self-care practices related to traditional, ಇದ್ರ ಬಗ್ಗೆ ನಾವೇನಾದ್ರೂ ಆಲೋಚನೆಗಳನ್ನು ಮಾಡಬೇಕಾಗುತ್ತೆ. ಜನರು ಕೂಡ ಗಂಭೀರವಾಗಿ ಆಲೋಚನೆ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಹೋಮ್ ಮೇಡ್ ಪ್ರಾಕ್ಟೀಸಸ್ ವಿತ್ ಹೈಜೆನಿಕ್ ಕಂಡೀಷನ್ಸ್, these are the very, very important aspects, because ಈಗೇನಾಗುತ್ತೆ, ಲೋ ಕಾಸ್ಟ್ ಎಕ್ವಿಪ್ಮೆಂಟ್ಸ್ ಆರ್ ನಾಟ್ ಅವೈಲೇಬಲ್, ಎಕ್ವಿಪ್ಮೆಂಟ್ಸ್ ಆರ್ ವೆರಿ ಹೈ ಪ್ರೈಸ್ಡ್. ಹಾಗಾಗಿ ಎಲ್ಲ ಮಿಡಲ್ ಕ್ಲಾಸ್ ಅವರು, ಕಾಮನ್ ಮ್ಯಾನ್ ಅವರು, ಇವರು ಯಾರಿಗೂ ಕೂಡ ಅದನ್ನ ಮೀಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಇದ್ರ ಬಗ್ಗೆನೂ ಕೂಡ ಸೋಷಿಯಲ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಆಕ್ಟ್ ಅಲ್ಲಿ ಇದನ್ನೆಲ್ಲಾನು ಕೂಡ ಸಾಮಾನ್ಯವಾದಂತ ಜನರಿಗೆ ತರೋದಕ್ಕೆ ಏನಾದ್ರು ಒಂದಷ್ಟು ಪ್ರಯತ್ನಗಳನ್ನ ಮಾಡಿದ್ರೆ ನಿಜವಾಗ್ಲೂ ಕೂಡ ಬಹಳ ಇನ್ನು, ಯಾಕಂತಂದ್ರೆ ದಿಸ್ ಇಸ್ ಅನ್ ಆಪರ್ಚುನಿಟಿ ಟು ಲರ್ನ್ ಲೆಸನ್ಸ್. ಅಫ್ಕೋರ್ಸ್ ದೇರ್ ಆರ್ ಚಾಲೆಂಜಸ್ ವೇರ್ ದೇರ್ ಆರ್ ಆಪರ್ಚುನಿಟೀಸ್. Naturally, there are challenges before us, before the government, before the society. You have to make corrections. Corrections are a continuous one. ಇವತ್ತು ನಾವು ಕರೆಕ್ಷನ್ಸ್ ಮಾಡ್ಕೊಳ್ಳಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ ಅಗೈನ್ ಇನ್ನು ಮತ್ತಷ್ಟು ಡಿಸಾಸ್ಟರ್ಸ್ ಆಗುತ್ತೆ ದೇಶದಲ್ಲಿ ಮತ್ತು ಜನರಿಗೆ. ಪ್ರೊಟೆಕ್ಷನ್ ಆಫ್ ಹ್ಯೂಮನ್ ರಿಸೋರ್ಸಸ್ ಇಸ್ ವೆರಿ, ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ನಮ್ಮ ಹ್ಯೂಮನ್ ರಿಸೋರ್ಸಸ್ ಅನ್ನ ಸರಿಯಾದ ದಾರಿಯಲ್ಲಿ ನಾವು ಉಪಯೋಗ ಮಾಡ್ಕೊಳ್ಬೇಕಾಗಿರುವಂತದ್ದು, ಸಮಾಜವನ್ನ, ದೇಶವನ್ನ, ರಾಜ್ಯವನ್ನ ಪ್ರಗತಿ ಮಾಡಬೇಕಾಗಿರುವಂತ ಜವಾಬ್ದಾರಿ, ಇಟ್ಸ್ ಎ ಕಲೆಕ್ಟಿವ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ. ಹಾಗಾಗಿ ಸರ್ಕಾರಗಳು ನಿರ್ಲಕ್ಷ್ಯ ಮಾಡಬಾರ್ದು. ಯಾವ ಟೈಮ್ ನಲ್ಲಿ ಏನ್ ಜವಾಬ್ದಾರಿಗಳನ್ನ ಸರ್ಕಾರಗಳು ಮಾಡಬೇಕು ಆ ಕೆಲಸವನ್ನ ಸರ್ಕಾರಗಳು ಮಾಡಿದ್ರೆ ಇಂಥ ದುರಂತಗಳು ಮತ್ತೆ ಮತ್ತೆ ಬರೋದಿಲ್ಲ, ಅಥವಾ ಮಿನಿಮೈಸ್ ಮಾಡ್ಕೊಳ್ಳೋದಕ್ಕೆ ಸಾಧ್ಯ ಆಗುತ್ತೆ. ಹಾಗಾಗಿ ರೋಲ್ ಅಂಡ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಆಫ್ ದ ಗವರ್ಮೆಂಟ್, ರೋಲ್ ಅಂಡ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಆಫ್ ದ ಪಬ್ಲಿಕ್ ಎಂಟರ್ಪ್ರಿನರ್ಸ್, ಇವರೆಲ್ಲರೂ ಕೂಡ ಬಹಳ ಇಂಪಾರ್ಟೆಂಟ್ ಇದೆ. ಹಾಗೇನೆ ರೋಲ್ ಆಫ್ ಅಂಡ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಆಫ್ ದಿಸ್ ಡಿಸೆಂಟ್ರಲೈಸೇಷನ್ ಮೆಂಬರ್ಸ್, ಪಬ್ಲಿಕ್ ರೆಪ್ರೆಸೆಂಟೇಟಿವ್ಸ್, ಇವರೆಲ್ಲರೂ ಕೂಡ ಬಹಳ ಶ್ರಮ ಪಡಬೇಕಾಗತ್ತೆ, ಒಂದು ಜವಾಬ್ದಾರಿಯನ್ನ ತಗೊಳ್ಬೇಕಾಗತ್ತೆ. ತಗೊಂಡಾಗ ಈ ತರದ ಸಮಸ್ಯೆಗಳನ್ನ ಕಡಿಮೆ ಮಾಡ್ಕೊಳ್ಬೇಕು. ಯಾಕಂದ್ರೆ ಕೆಲವನ್ನ ನ್ಯಾಚುರಲ್ ಡಿಸಾಸ್ಟರ್ಸ್ ಅನ್ನ ನಾವು ಏನು ಮಾಡ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ. ಮತ್ತೆ ಐ ಅಪೀಲ್ ಟು ದ ಗವರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಟು ಇಂಟ್ರೊಡ್ಯೂಸ್ ದ ನ್ಯಾಷನಲ್ ಡಿಸಾಸ್ಟರ್ಸ್ ಅಮೆಂಡ್ಮೆಂಟ್ ಆಕ್ಟ್. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಅಲ್ಲಿ ಜನರಿಗೆ ಕಾಂಪನ್ಸೇಷನ್ ಕೊಡೋದನ್ನ ಅವರು ವಿಡ್ರಾ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ ಗವರ್ಮೆಂಟ್ ಆಫ್, ವಿಚ್ ಇಸ್ ನಾಟ್ ಕರೆಕ್ಟ್. ಇಟ್ಸ್ ಅನ್ ಅನ್ಫೇರ್ ಆನ್ ದ ಪಾರ್ಟ್ ಆಫ್ ದ ಗವರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ. ಹಾಗೆ ಮಾಡಬಾರ್ದು. ಯಾಕಂದ್ರೆ ಇನ್ ದ ಇಂಟ್ರೆಸ್ಟ್ ಆಫ್ ಕಾಮನ್ ಮ್ಯಾನ್ ಅಂಡ್ ಮಿಡಲ್ ಕ್ಲಾಸ್ ಆ ಆಕ್ಟ್ ಅನ್ನು ಅವರು ರೀಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ಬೇಕಾಗತ್ತೆ. ರೀಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಿ ನಮ್ಮ ಜನರಿಗೆ, ಅದರಿಂದನೇ ಜನರು ಬದುಕೋದಿಲ್ಲ. ಆದ್ರೆ ಒಂದು ಸರ್ಕಾರ ಒಂದು ಇಟ್ ಹ್ಯಾಸ್ ಟು ಎಕ್ಸಿಬಿಟ್ ಇಟ್ಸ್ ಹ್ಯುಮ್ಯಾನಿಟೇರಿಯನ್ ಅಪ್ರೋಚ್. ಆ ಕೆಲಸವನ್ನ ಸರ್ಕಾರ ಮಾಡ್ಬೇಕು ಅಂತ ಹೇಳಿ ನಾವು ಒತ್ತಾಯ ಮಾಡ್ತಾನೆ. ಮತ್ತೆ ವಿಶೇಷವಾಗಿ ಪ್ರತಾಪ್ ಹೆಗ್ಡೆನು ಕೂಡ ತುಂಬಾ ಚೆನ್ನಾಗಿ ಮಾಡರೇಟ್ ಮಾಡಿದ್ದಾರೆ. ಪ್ರಕಾಶ್ ಅವರೇ, ತಾವು ಬಹಳ ಆಸಕ್ತಿಯನ್ನು ತಗೊಂಡು ಎಲ್ಲರನ್ನು ಇನ್ವಾಲ್ವ್ ಮಾಡಿದ್ದೀರಿ. ಅದಕ್ಕಾಗಿ ತಮಗೆ ಭಾಗವಹಿಸಿದಂತ ಎಲ್ಲ ಸ್ನೇಹಿತರು, ನಮ್ಮ ಶಾಂತ್ ಕುಮಾರ್ ಅವರು, ಗಾಯತ್ರಿ ಅವರು, ಅಭಯ್ ಕುಮಾರ್ ಅವರು, ಹೀಗೆ ಬಹಳಷ್ಟು ಜನರು ಇನ್ನೂ ಕೂಡ ಎಕ್ಸ್ಪರ್ಟ್ಸ್ ಎಲ್ಲರೂ ಕೂಡ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಅವರೆಲ್ಲರಿಗೂ ಕೂಡ ನಾನು ವಂದಿಸ್ತೇನೆ. ಸೊ ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ ಪ್ರೊವೈಡಿಂಗ್ ಮಿ ಅನ್ ಆಪರ್ಚುನಿಟಿ ಟು ಪಾರ್ಟಿಸಿಪೇಟ್ ಇನ್ Zoom's meeting. ಥ್ಯಾಂಕ್ ಯು.
ಥ್ಯಾಂಕ್ಸ್ ಸುದರ್ಶನ್ ಅವರೇ. ಕುರುಬೂರು ಶಾಂತಕುಮಾರ್ ಇದ್ರ ವೆಬಿನಾರಲ್ಲೇ ಶಾಂತಕುಮಾರ್ ಕಾಣಿಲ್ಲ ಅವರು, ಪಾಪ ಶಾಂತಕುಮಾರ್ ಇದ್ರ ಶಾಂತಕುಮಾರ್ ಅವರಿಗೆ ಈಗ ತಾವು ಮಾತಾಡಿ. ನಿಮ್ಮ ಒಂದು ಹೊಸ ಅನುಭವ ಇದೆಯಲ್ಲ, ಬಹಳ ಮುಖ್ಯವಾಗಿರ್ತಕ್ಕಂಥದ್ದು. ಮೈಸೂರಲ್ಲಿ ಕರೋನಾ ಪಡೆ ಅನ್ನು ರಚಿಸಿದ್ರಿ. ಇವತ್ತಿನ ಸಭೆಯ ಮೂಲಕ ನೀವು ರೈತರ ಹಿತದೃಷ್ಟಿಯಿಂದ ಯಾವ ರೀತಿ ಸಜೆಷನ್ಸ್ಗಳು ಈಗ ನಿಮ್ಮಿಂದ ಬರ್ಬೋದು ಅಂತ ಹೇಳಿ ಈಗ ತಾವು ಮಾತಾಡಿ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನಾನು ಬಹಳ ಒಳ್ಳೊಳ್ಳೆ ವಿಚಾರಗಳು ನಾನು ಕೇಳಿದ್ದೀನಿ. ತುಂಬಾ ಒಳ್ಳೆಯ ಒಂದು ಸಲಹೆಗಳು ಬಂದಿದೆ. ಆ ಸಲಹೆಗಳ ಜೊತೆ ನಾನು ಕೂಡ ಕೊರೋನಾ ಲಾಕ್ಡೌನ್ ಆದ ನಂತರ ಮನೆಯಲ್ಲೇ ಯಾಕೆ ಕೂರ್ಬೇಕು, ಏನಾದರೂ ಸಮಾಜಕ್ಕೆ ಸೇವೆ ಮಾಡೋಣ ಅಂತೇಳಿ ವೈದ್ಯರ ಜೊತೆ ಸಂಪರ್ಕ ಮಾಡಿ ಒಂದು 8 ಜನ ವೈದ್ಯರನ್ನ ಸೇರಿಸ್ಕೊಂಡು ಸುಮಾರು 60 ದಿನಗಳಿಂದ ಗ್ರಾಮೀಣ ಜನರ ಕೊರೋನಾ ಸೇವಾ ಪಡೆ ಅಂತ ಮಾಡಿ ಸುಮಾರು 2500 ರೋಗಿಗಳಿಗೆ ಆನ್ಲೈನ್ ಮೂಲಕ ಚಿಕಿತ್ಸೆಯನ್ನ ಕೊಟ್ಟಿದ್ವಿ. ಅವ್ರನ್ನ ದೊಡ್ಡ ಅಪಾಯದಿಂದ ಪಾರು ಮಾಡಲಿಕ್ಕೆ ನಮ್ಮ ಟೀಮ್ ಮತ್ತು ಸಹಾಯವಾಣಿ ಮೂಲಕ ಕೂಡ ತುಂಬಾ ಕೆಲಸ ಮಾಡಿದ್ದೀವಿ. ನಾವು ಸ್ವಯಂ ಪ್ರೇರಿತವಾಗಿ ನಾವು ಯಾರಿಂದಲೂ ಹೇಳಿಸ್ಕೊಳ್ಳಿಲ್ಲ. ಸ್ವಯಂ ಪ್ರೇರಿತವಾಗಿ ನಾವೇ ಒಂದು ಜನರಿಗೆ ಒಳ್ಳೇದಾಗಬೇಕು, ಗ್ರಾಮೀಣ ಜನರಿಗೆ ಅಂತ ಹೇಳಿ ನಾವು ಈ ಕೆಲಸವನ್ನು ಮಾಡಿದ್ದೇವೆ. ಆರಂಭದಲ್ಲಿ ಸರ್ಕಾರಗಳು ಹೆಚ್ಚು ನಗರ ಪ್ರದೇಶಗಳಿಗೆ ಒತ್ತು ಕೊಡುವಂತ ಚಿಂತನೆಗಳು ಮಾಡಿದ್ರು. ನಾವು ಅದನ್ನ ಮಾಧ್ಯಮಗಳ ಮೂಲಕ ಬೇರೆ ಬೇರೆ ಕ್ಷೇತ್ರದಲ್ಲಿ ನೋಡಿದ್ವಿ. ಆಗ ಈ ಗ್ರಾಮೀಣ ಜನರ ಸಮಸ್ಯೆಗಳಿಗೆ ಪರಿಹಾರ ಸಿಗೋದು ಕಷ್ಟ ಆಗ್ತದೆ ಅನ್ನುವಂಥ ಕಾರಣದಿಂದ ಸ್ವಲ್ಪ ಮಟ್ಟಿಗೆ ನಾವೇ ಮುಂಚೂಣಿಯಲ್ಲಿ ಈ ಕೆಲಸವನ್ನ ಮಾಡಿದ್ವಿ. ಇರ್ಲಿ, ಅದು ಕೂಡ ಒಂದು ಬದಿಗೊತ್ತಬೇಕಾದಂಥ ವಿಚಾರ. ನಮ್ಮ ವೈದ್ಯರುಗಳು ಕೂಡ ತುಂಬಾ ಜನ ನಮ್ಮ ಜೊತೆ ಸಲಹೆಯನ್ನ ಕೊಟ್ಟರು, ಗೂಗಲ್ ಮೀಟಲ್ಲಿ ಭಾಗವಹಿಸಿದ್ರು. ಪ್ರಖ್ಯಾತಿಯಾದಂಥ ಡಾಕ್ಟರ್ಗಳು ಕೂಡ 2 ದಿವಸಕ್ಕೊಮ್ಮೆ ಗೂಗಲ್ ಮೀಟಲ್ಲಿ ಸಭೆ ಮಾಡಿದ್ವಿ. ರೈತರ ಮತ್ತು ಜನರ ಸಮಸ್ಯೆಗಳಿಗೆ ಉತ್ತರವನ್ನು ಹೇಳಿದ್ವಿ. ಸುಮಾರು 500-600 ಜನ ನಮ್ಮ ಗೂಗಲ್ ಮೀಟಲ್ಲಿ ಭಾಗವಹಿಸ್ತಾ ಇದ್ರು. ಅವರಿಗೆ ಧೈರ್ಯ ತುಂಬುವಂತ ಕೆಲಸ ಆಯಿತು. ತುಂಬಾ ನಮ್ಮ ಒಂದು ಗ್ರಾಮೀಣ ಜನರ ಕೊರೋನಾ ಸೇವಾ ಪಡೆಗೆ ತುಂಬಾ ಎಲ್ಲ ಕಡೆಯಿಂದ ಒಳ್ಳೆಯ ಪ್ರತಿಕ್ರಿಯೆ ಬಂತು. ಅದು ಒಂದು ನಮ್ಮಿಂದ ಆದಂತ ಒಂದು ಕೆಲಸ ಅಂತ ನಾನು ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತೀನಿ. ಆದ್ರೆ ಅದೇ ಸಂದರ್ಭದಲ್ಲಿ ನಾವು ಕೆಲವಾರು ಭಾಗದಲ್ಲಿ ಹಳ್ಳಿಗಳಲ್ಲಿ ಹೋಗಿ ನಾವು ಜನರನ್ನ ಒಂದು ಮಾತಾಡ್ತಾ ಇದ್ದಾಗ ಹಳ್ಳಿಗಳಲ್ಲಿ ಯಾರು ಕೂಡ ಜನರು ಮನೆಯಿಂದ ಈಚೆ ಬರ್ತಾ ಇರಲಿಲ್ಲ. ಆಗ ಹಳ್ಳಿಗಳಲ್ಲಿ ಆಶಾ ಕಾರ್ಯಕರ್ತರು ಮಾತ್ರ ಮನೆಯಿಂದ ಈಚೆ ಬಂದು ಮನೆಗೆ ಹೋಗಿ ಪರೀಕ್ಷೆ ಮಾಡಿಸುವಂಥದ್ದು, ಧೈರ್ಯ ತುಂಬುವಂಥದ್ದು, ಮತ್ತೆ ಹಾಸ್ಪಿಟ್ಲ್ ಕರ್ಕೊಂಡು ಹೋಗುವಂಥದ್ದು. ಕೆಲವು ಕಡೆ ಆಶಾ ಕಾರ್ಯಕರ್ತರ ಜೊತೆ ಸ್ಥಳೀಯವಾಗಿರ್ತಕ್ಕಂಥ ಲೀಡರ್ಗಳು ಜಗಳ ಮಾಡಿದ್ದಾರೆ. ನಾವು ಹೋಗೋದೆಷ್ಟೋ ಬಿಟ್ರೆಷ್ಟೋ, ನೀನ್ ಯಾರು ಕೇಳಕ್ಕೆ ಅಂತೆಲ್ಲ ಜಗಳ ಮಾಡಿದ್ರು ಕೂಡ ಅವ್ರು ಬಿಡದೆ ಕನ್ವಿನ್ಸ್ ಮಾಡಿ ತಗೊಂಡೋಗಿ ಹಾಸ್ಪಿಟಲ್ ಸೇರಿಸಿದ್ದಾರೆ. ಅದು ಕೂಡ ಪ್ರಸಂಗಗಳನ್ನ ನೋಡಿದೀವಿ. ಕೆಲವೊಂದು ಕಡೆ ಕೊರೋನಾ ಒಂದು ಇದು ಮಾಡಿದ್ರಲ್ಲ ಆಸ್ಪತ್ರೆಗಳು, ಸರ್ಕಾರ ಆ ಒಂದು ಕೊರೋನಾ ಚಿಕಿತ್ಸಾ ಕೇಂದ್ರಗಳಲ್ಲಿ ಕ್ಲೀನ್ ಮಾಡೋರು ಸ್ವಚ್ಛತಾ ಕಾರ್ಮಿಕರು ಇರ್ತಿರ್ಲಿಲ್ಲ. ಅಂತ ಕಡೆ ಯಾರು ರೋಗಿಗಳು ಆ ಸ್ವಚ್ಛತೆ ಇಲ್ಲ ಅಂತೇಳಿ ಗಲಾಟೆ ಮಾಡ್ತಿದ್ರು. ಅಂತ ಟೈಮಲ್ಲಿ ಸ್ವಚ್ಛತೆ ಕಾರ್ಮಿಕರನ್ನ ಕರ್ಕೊಂಡ್ಬಂದು ಕೆಲಸ ಮಾಡಿಸ್ತಕ್ಕಂಥ ಕೆಲಸವನ್ನ ಕೂಡ ಕೆಲವೊಂದು ರೆವಿನ್ಯೂ ಆಫೀಸರ್ಸ್ ಕೆಲಸ ಮಾಡಿದ್ದಾರೆ. ಸ್ವಚ್ಛತಾ ಕಾರ್ಮಿಕರು ಕೂಡ ತಮ್ಮ ಪ್ರಾಣವನ್ನ ಲೆಕ್ಕಿಸದೆ ಕೆಲಸವನ್ನ ಮಾಡಿದ್ದಾರೆ. ಅದು ಬಹಳ ಗ್ರೇಟ್. ಅದ್ರ ಜೊತೆಗೆ ನರ್ಸ್ಗಳು ಕೂಡ ತುಂಬಾ ಒಳ್ಳೆ ಕೆಲಸ ಮಾಡಿದ್ದಾರೆ. ಇದೆಲ್ಲ ಒಂದು ನಿಮಗೆ ಗೊತ್ತಿರತಕ್ಕಂಥ ವಿಚಾರನೆ. ಆದ್ರೂ ಕೂಡ ನಾವು ಕಂಡಂತದ್ನ ಸತ್ಯವನ್ನ ನಿಮ್ಮ ಮುಂದೆ ಹೇಳಲೇಬೇಕಾಗ್ತದೆ. ಇದೆಲ್ಲ ನಾವು ಸ್ವಚ್ಛತಾ ಕಾರ್ಮಿಕರು, ಆಶಾ ಕಾರ್ಯಕರ್ತರು ಮತ್ತು ನರ್ಸ್ಗಳ ಬಗ್ಗೆ ನಾವು ಇಡೀ ದೇಶದ ಜನ ಸಂಪೂರ್ಣವಾಗಿ ನಾವು ಹೆಚ್ಚಿನ ಒಂದು ಗೌರವವನ್ನ ಕೊಡ್ಬೇಕು ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ಅಭಿಪ್ರಾಯ. ಮತ್ತೆ ಅವ್ರು ಅದೇ ಜೊತೆಗೆ ನಾನು ಕೆಲವು ಪಾಯಿಂಟ್ಸ್ಗಳನ್ನ ನಿಮ್ ಮುಂದೆ ಇಡ್ಲಿಕ್ಕೆ ಬಯಸ್ತೀನಿ. ಈಗ CSR ಫಂಡ್ ಅಂತ ಹೇಳಿದಾರಲ್ಲ, CSR ಫಂಡ್ ಅಲ್ಲಿ ಕೆಲವು ಮಿಸ್ಯುಟಿಲೈಸೇಷನ್ ಆಗ್ತಾ ಇದೆ. ಈಗ ಕೇಂದ್ರ ಸರ್ಕಾರಕ್ಕೆ, ರಾಜ್ಯ ಸರ್ಕಾರಕ್ಕೆ ಕೆಲವೊಂದು ವೈದ್ಯಕೀಯ ಉಪಕರಣಗಳನ್ನ ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಅದು ಎಲ್ಲೋ ಮೂಲೆಯಲ್ಲಿ ಬಿದ್ದೋಯ್ತು, ಅದನ್ನ ಬಳಕೆ ಮಾಡ್ಲಿಲ್ಲ. ಅದರಿಂದ ಆ ಕಾನೂನು ಪ್ರಕಾರ ಅವರು ಕೊಡುವಂತ ಕೆಲಸ ಮಾಡ್ತಾರೆ, ಅದರ ಸದ್ಬಳಕೆ ಆಗ್ತಕ್ಕಂಥ ಸನ್ನಿವೇಶಗಳು ಕಡಿಮೆ ಆಗ್ತಾ ಇದೆ. ಅದರ ಬದಲು ಆ ಆಕ್ಟನ್ನೇ ಬದಲಾವಣೆ ಮಾಡಿ ಯಾರು CSR ಇದನ್ನ ಖರ್ಚು ಮಾಡ್ತಾರೆ ಅವರಿಗೆ ಸ್ವಯಂ ಪ್ರೇರಿತವಾಗಿ ಕೆಲವು ಮಾನದಂಡಗಳನ್ನ ರೂಪಿಸಿ ಆ ಕಾಯ್ದೆಯನ್ನು ತಿದ್ದುಪಡಿ ಮಾಡಿದ್ರೆ ಸ್ವಲ್ಪ ಅನುಕೂಲ ಆಗ್ತದೆ ಹೆಚ್ಚು ಜನರಿಗೆ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ಒಂದು ವಿಚಾರ. ಎರಡನೇದಾಗಿ ನಮ್ಮ ಸುದರ್ಶನ್ ಅವ್ರು ಹೇಳಿದ್ರು MBBS ಡಾಕ್ಟರ್ಗಳು 4-5 ವರ್ಷ ಹಳ್ಳಿಗಳಲ್ಲಿ ಸೇವೆ ಮಾಡ್ಬೇಕು ಅಂತ. ಅದರ ಬದಲು MBBS ಅಲ್ಲಿ ಸೀಟ್ ಅಲಾಟ್ಮೆಂಟ್ ಮಾಡುವಾಗಲೇ ಯಾರು ಅಲಾಟ್ಮೆಂಟ್ ಮಾಡ್ತೀವಿ ಅವರೆಲ್ಲ ಕಡ್ಡಾಯವಾಗಿ ನಾವು 5 ವರ್ಷ ಹಳ್ಳಿನಲ್ಲಿ ಸೇವೆ ಮಾಡ್ತೀವಿ ಅಂತ ಬರ್ಕೊಟ್ರು ಮಾತ್ರ ಅಡ್ಮಿಷನ್ ಕೊಡ್ಬೇಕು ಅನ್ನುವಂತ ನಿಯಮ ತಂದ್ರೆ, ಈಗ IAS ಅಧಿಕಾರಿಗಳು ಸೆಲೆಕ್ಷನ್ ಮಾಡಿದ್ಮೇಲೆ ವಿಲೇಜ್ ಅಕೌಂಟೆಂಟು, ರೆವಿನ್ಯೂ ಇನ್ಸ್ಪೆಕ್ಟರು, ತಹಸೀಲ್ದಾರರು, AC ಎಲ್ಲವನ್ನ ಟ್ರೈನಿಂಗ್ ಮಾಡ್ಕೊಂಡು ಬರ್ತಾರೆ, ಬಂದು ಆಡಳಿತ ವ್ಯವಸ್ಥೆ ಬರ್ತಾರೆ. ಡಾಕ್ಟರ್ಗಳಿಗೆ ಯಾಕೆ ಆ ಕೆಲಸ ಮಾಡಬಾರ್ದು? ಇದನ್ನು ಕೂಡ ನೀವು ಸರ್ಕಾರಕ್ಕೆ ಸಜೆಷನ್ ಕೊಡಬೇಕಾಗ್ತದೆ ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ವಿಚಾರ. ಮತ್ತು ನನ್ನ ಬಹಳ ಮುಖ್ಯವಾಗಿ ಹೇಳ್ತಕ್ಕಂಥದ್ದು, ಈ ಒಂದು ಸನ್ನಿವೇಶ ಇವತ್ತು ಪ್ರಪಂಚದಲ್ಲಿ ಒಂದು ಹೊಸ ದಿಕ್ಕನ್ನು ತೋರಿಸ್ತಾ ಇದೆ. ಯಾವ ದಿಕ್ಕು ಅಂತ ಹೇಳಿದ್ರೆ, ಪ್ರಬಲ ರಾಷ್ಟ್ರಗಳು ದುರ್ಬಲ ರಾಷ್ಟ್ರಗಳನ್ನ ಈ ರೀತಿಯ ಒಂದು ವೈರಾಣುಗಳನ್ನ ಸೃಷ್ಟಿ ಮಾಡಿ ಯುದ್ಧ ರೂಪದಲ್ಲಿ ಆ ರಾಷ್ಟ್ರಗಳನ್ನ ನಾಶ ಮಾಡುವಂತ, ಆ ರಾಷ್ಟ್ರಗಳ ಒಂದು ಬಲವರ್ಧನೆಯನ್ನ ಕಡಿಮೆ ಮಾಡುವಂತ ತಂತ್ರಗಾರಿಕೆಯನ್ನ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಅನುಸರಣೆ ಮಾಡಿದ್ರು ಕೂಡ ತಪ್ಪಾಗ್ಲಿಕ್ಕಿಲ್ಲ ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ಅಭಿಪ್ರಾಯ. ಆ ಒಂದು ಹಿನ್ನೆಲೆಯಲ್ಲಿ ರಾಷ್ಟ್ರದ ಸರ್ಕಾರಗಳು ಇದ್ರ ಬಗ್ಗೆ ಗಂಭೀರವಾದಂತ ಚಿಂತನೆ ಮಾಡಿ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಎಲ್ಲ ಆರೋಗ್ಯ ಸಮಸ್ಯೆಗಳಿಗೂ ನಾವು ಸಿದ್ಧರಾಗಿದ್ದೇವೆ ಅನ್ನುವಂಥ ಸಿದ್ಧತೆಯನ್ನ ಮಾಡ್ಕೊಳ್ಳಿಕ್ಕೆ ಸರ್ಕಾರಕ್ಕೆ ಸಲಹೆಯನ್ನು ಕೊಡಬೇಕಾಗ್ತದೆ. ಮತ್ತೆ ಬಹಳ ಮುಖ್ಯವಾಗಿ ಜನಪ್ರತಿನಿಧಿಗಳು ತಮ್ಮ ಒಂದು ಬದ್ಧತೆಯನ್ನ ಮರೆತರು. ಈ ಎರಡನೇ ಅಲೆಯಲ್ಲಿ ಎಲ್ಲ ಬಹುತೇಕ ಜನಪ್ರತಿನಿಧಿಗಳು, ವಿರೋಧ ಪಕ್ಷಗಳು, ಆಡಳಿತ ಪಕ್ಷಗಳು ಎಲ್ಲರೂ ಕೂಡ ನೆಗ್ಲೆಕ್ಟ್ ಮಾಡೋರು. ಮತ್ತೆ ಜನರಿಗೆ ತಪ್ಪು ಸಂದೇಶಗಳನ್ನ ಕೊಟ್ಟರು. ಈ ತಪ್ಪು ಸಂದೇಶಗಳನ್ನ ಕೊಟ್ಟಂತ ಕಾರಣದಿಂದನೇ ಕೊರೋನಾ ತುಂಬಾ ಜಾಸ್ತಿ ಆಯ್ತು ಅಂತಕ್ಕಂಥದ್ದು ನಮ್ಮೆಲ್ಲರ ಅನಿಸಿಕೆ ಮತ್ತು ಅಲ್ಲಿ ಕಂಡಂತ ಒಂದು ಪರಿಸ್ಥಿತಿ. ಅದು ಅಂತ ಒಂದು ಪರಿಸ್ಥಿತಿ ನಿರ್ಮಾಣ ಆಗ್ಲಿಕ್ಕೆ ಬಿಡಬಾರ್ದು. ಜನಪ್ರತಿನಿಧಿಗಳಿಗೆ ಎಲ್ರಿಗೂ ಜವಾಬ್ದಾರಿ ಇರ್ತದೆ. ಅವರು ಜನರಿಂದ ಆಯ್ಕೆಯಾಗಿರೋರು, ಅವರು ವಿವೇಕದಿಂದ ಜನರಿಗೆ ಮಾದರಿಯಾಗಿ ಕೆಲಸ ಮಾಡಿದ್ರೆ ಸಮಾಜಕ್ಕೆ ಒಳ್ಳೆ ವಾತಾವರಣ ಸೃಷ್ಟಿಯಾಗ್ತದೆ. ಸಮಾಜನೂ ಕೂಡ ಒಳ್ಳೆ ರೀತಿ ಮುಂದೆ ಹೋಗ್ಲಿಕ್ಕೆ ಅನುಕೂಲ ಆಗ್ತದೆ. ಈ ದಿಕ್ಕಿನಲ್ಲಿ ಚಿಂತನೆ ಮಾಡಬೇಕು ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ಸಲಹೆ. ಮತ್ತು ಇವತ್ತಿನ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನ ಆರ್ಗನೈಸ್ ಮಾಡಿ ಒಳ್ಳೊಳ್ಳೆ ಜನರನ್ನ ಚರ್ಚೆ ಮಾಡ್ಲಿಕ್ಕೆ ಬಿಟ್ಟಿರ್ತಕ್ಕಂಥ ಪ್ರಕಾಶ್ ಕಮ್ಮರಡಿ ಅವರು ಒಂದು ಒಳ್ಳೆಯ ವೇದಿಕೆಯನ್ನ ಸೃಷ್ಟಿ ಮಾಡಿದ್ದಾರೆ. ಮುಂದಿನ ದಿನಗಳಲ್ಲೂ ಕೂಡ ಗ್ರಾಮೀಣ ಪ್ರದೇಶದ ಬಗ್ಗೆ ಹೆಚ್ಚಿನ ಒತ್ತನ್ನು ಕೊಟ್ರೆ ನಾವು ಎಲ್ಲಾ ತರದಲ್ಲಿ ಇಡೀ ರಾಜ್ಯವ್ಯಾಪಿ ಏನ್ ಬೇಕಾದ್ರೂ ಕಾರ್ಯಕ್ರಮ ಮಾಡಿ ಆ ಹಳ್ಳಿಯ ಜನರಿಗೆ ಮೋಟಿವೇಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ನಾವು ಸಿದ್ಧರಿದ್ದೀವಿ. ತುಂಬಾ ಜನ ಡಾಕ್ಟರ್ಗಳು ಹಳ್ಳಿಗಳು ಬಂದು ಸೇವೆ ಮಾಡ್ತೀವಿ ಅನ್ನುವಂಥ ಭಾವನೆಗಳನ್ನ ವ್ಯಕ್ತಪಡಿಸ್ತಾ ಇದ್ದಾರೆ. ಮೊನ್ನೆ ನಾವು ಒಂದು ಹಳ್ಳಿಯಲ್ಲಿ ಕಾರ್ಯಕ್ರಮ ಮಾಡಿದಾಗ ಸುಮಾರು 500 ಜನರು ಬಂದಿರು. 10 ಜನ ವೈದ್ಯರು ಅವರಿಗೆ ಚಿಕಿತ್ಸೆ ಮಾಡಿದ್ರು, ಅವರಿಗೆ ಧೈರ್ಯ ತುಂಬಿದ್ರು. ಆ ರೀತಿಯ ಕಾರ್ಯಕ್ರಮಗಳನ್ನ ನಾವು ಮಾಡಿದ್ರೆ ಅನುಕೂಲ ಆಗ್ತದೆ ಅನ್ನುವಂಥ ಮಾತನ್ನ ಹೇಳ್ತಾ ನಾನು ಹೆಚ್ಚಿಗೆ ಸಮಯವನ್ನು ತಗೊಳ್ಳದೆ ನನಗೆ ಒಂದು ಅವಕಾಶವನ್ನು ಕೊಟ್ಟಂತ ಎಲ್ಲರಿಗೂ ಒಂದ್ಸಿ ನನ್ನ ಮಾತನ್ನ ಮುಕ್ತಾಯ ಮಾಡ್ತೀನಿ.
ಥ್ಯಾಂಕ್ ಯು ಶಾಂತಕುಮಾರ್ ಅವರೇ. ಈಗ ಗಾಯತ್ರಿ ಅವ್ರು ಇದ್ರಲ್ವಾ?
ಇದೀನಿ.
ಓಕೆ, ಆಮೇಲೆ ಪ್ರಸನ್ನ ಇದ್ರ? ಪ್ರಸನ್ನ ಎನ್ಗೌಡ, ಅಭಯ್, ಪ್ರಸನ್ನ ಎನ್ಗೌಡ, ಅಭಯ್, ಆಮೇಲೆ ರಾಜಾರಾಮ್ ತೆಲ್ಲೂರು ಕೂಡ ಮಾತಾಡ್ಬೋದು. ಈಗ ಗಾಯತ್ರಿ ಅವರು.
ಈಗಾಗ್ಲೇ ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಈಗಾಗ್ಲೇ ಬಹಳ ಸಮಯನೂ ಆಗಿದೆ, ಸಮಯ ಮೀರೋಗ್ಬಿಟ್ಟಿದೆ. ಮತ್ತೆ ಜೆಂಡರ್ ಯಾವಾಗ್ಲೂ ಜೆಂಡರ್ ಕೊನೆಯಲ್ಲಿ ಇರ್ಬೇಕಲ್ವಾ, ಅದಿಲ್ಲದಿದ್ರೆ ಶೋಭೆ ಇರಲ್ಲ. ಹಾಗಾಗಿ ನಾನು ಕೊನೆಗೆ ಬಂದಿದ್ದೀನಿ. ಈಗ ಎಲ್ಲರೂ ಸಾಕಷ್ಟು ಇನ್ಪುಟ್ಗಳನ್ನ ಕೊಟ್ಟಿದ್ದಾರೆ. ಅದು ಯಾವ್ದಕ್ಕೂ ಮತ್ತೆ ನಾನು ರಿಪೀಟ್ ಮಾಡಕ್ ಹೋಗ್ದಿರಾ, ಈಗ ಕಾರ್ಪೊರೇಟ್ ಸೋಷಿಯಲ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿಯಲ್ಲಿ ಏನ್ ಮಾಡ್ಬೋದು ಅನ್ನೋ ವಿಷಯದ ಬಗ್ಗೆನೇ ಇಲ್ಲಿ ಹೆಚ್ಚು ಫೋಕಸ್ ಆಗ್ತಾ ಇದೆ. ಮತ್ತೆ ಹೆಲ್ತ್ ಕೇರ್ ಸಿಸ್ಟಮ್ ಬಗ್ಗೆ ಫೋಕಸ್ ಆಗ್ತಾ ಇದೆ. ಅದ್ರ ಜೊತೆಗೆ ನಂಗೆ ಈಗ ತುಂಬಾ ಮುಖ್ಯವಾಗಿ ಹಳ್ಳಿಗಳಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಾ ನಮ್ ಮುಂದೆ ಕಂಡು ಬರ್ತಾ ಇರೋದು ಈ ಭಯಂಕರವಾದ ಸಾವುಗಳು. ಮತ್ತೆ ಹಳ್ಳಿಗಳಲ್ಲಿ ಈ ಕರೋನಾ ಸಂದರ್ಭದಲ್ಲಿ ಎಸ್ಪೆಷಲಿ ಈ ವರ್ಷ ಆಗಿರುವಂತ ಸಾವುಗಳು, ಆ ಭಯ, ಆ ಒಂದು ತಪ್ಪಿತಸ್ಥ ಮನೋಭಾವನೆ, ಆ ಅಪನಂಬಿಕೆ, ಆ ಮುಚ್ಚುಮರೆ ಜನರಲ್ಲಿ ಬಂದಿರುವಂತದ್ದು, ಅದಕ್ಕಿಂತ ಒಂದ್ ರೀತಿಯ ಈ ಹೊಸ ರೀತಿಯ ಅಸ್ಪೃಶ್ಯತಾ ಮನೋಭಾವ, ಈ ತರದ ವಿಚಿತ್ರ ಸನ್ನಿವೇಶ ನಮ್ಮ ಹಳ್ಳಿಗಳಲ್ಲಿ ಇವತ್ತು ಸೃಷ್ಟಿಯಾಗಿದೆ. ಇಂಥದನ್ನ ನೋಡ್ತಾ ಇದ್ದಾಗ ಈಗಷ್ಟೇ ನಾನು ಈ ಕಾರ್ಯಕ್ರಮ ನಾನು ಪ್ರಾರಂಭದಿಂದಲೂ ಇದ್ದೀನಿ. ಅದಕ್ಕೆ ಮುಂಚೆ ನಾನು ಒಂದು ರೈತನ ರೆಕಾರ್ಡ್ ಮಾಡ್ತಾ ಇದ್ದೆ ನಮ್ಮ ಪತ್ರಿಕೆಗೋಸ್ಕರ. ಮುಧೋಳ್ ತಾಲೂಕಿಂದ ಮುಗಳಗೋಡ್ ಅನ್ನೋ ಊರಿನಲ್ಲಿ ಆತ ಹೇಳ್ತಾ ಇದ್ರು, ಈ ವರ್ಷ ಮಾರ್ಚ್ ನಿಂದ ಎಲ್ಲಿವರೆಗೆ ನಮ್ಮೂರಿನಲ್ಲಿ, ಅದು ದೊಡ್ಡ ಊರು, 1000 ಕುಟುಂಬಗಳು ಇರ್ಬೋದು, 60-70 ಜನರ ಸಾವಾಗ ಹೋಗಿದೆ. ಒಂದೊಂದು ಹಳ್ಳಿಗಳಲ್ಲಿ ಅಷ್ಟಷ್ಟು ಸಾವುಗಳು ಲೆಕ್ಕವೇ ಇಲ್ಲ. ಸರ್ಕಾರ ಕೊಡ್ತಾ ಇರೋ ಅಂಕಿಅಂಶಕ್ಕೂ ಹಳ್ಳಿಗಳಲ್ಲಿ ಆಗಿರುವಂತಹ ಸಾವುಗಳಿಗೂ ಒಂದ್ ರೀತಿಯ ಅರ್ಥ ಸಂಬಂಧವೇ ಇಲ್ಲ ಅನ್ನೋ ರೀತಿನಲ್ಲಿ ಸಾವುಗಳಾಗಿದೆ. ಇನ್ನೊಂದು, ಜನರಲ್ಲಿ ಈಗ ರೈತರ ವಿಷಯ ಕುರುಬೂರು ಶಾಂತಕುಮಾರ್ ಅಷ್ಟೊಂದು ಫೋಕಸ್ ಮಾಡ್ಲಿಲ್ಲ ಅವರು. ಇಲ್ಲಿ ರೈತರಲ್ಲಿ ಈಗ ಏನಾಗಿದೆ ಅಂತಂದ್ರೆ, ಈ ವರ್ಷದಲ್ಲಿ ಸಂಪೂರ್ಣ ಅವರು ಹಣ್ಣು ತರಕಾರಿಗಳು ಬೆಳೆದಂತ ರೈತರು ಸಂಪೂರ್ಣ ಲಾಸಿಗೆ, ಮತ್ತೆ ಇವಾಗಲೇ ಈಗ ಸ್ವಲ್ಪ ಚರ್ಚೆ ಆಗಿರೋ ರೀತಿನಲ್ಲಿ ಎಲ್ಲರೂ ಮೊನೋಕ್ರಾಪಿಂಗ್ ಗೆ ಹೋಗಿರುವಂತ ಸಂದರ್ಭದಲ್ಲಿ ಅವರು ಬೆಳೆದ ಅಷ್ಟನ್ನು ಅವರು ಲಾಸ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ಒಂದು 10% ಕೂಡ ಅವ್ರ ಕೈಯಲ್ಲಿ ಮಾರಾಟ ಮಾಡಕ್ಕಾಗಿಲ್ಲ. ಅಕ್ಕಪಕ್ಕ ಹಳ್ಳಿಗಳಿಗೆ ಹೋಗಿ ಪ್ರಯತ್ನ ಬಿದ್ದಾಗ ಕೂಡ ಒಂದು 10-20% ಮಾರಾಟ ಆಗಿರ್ಬೋದು, ಉಳಿದಿದಷ್ಟು ಅವ್ರಿಗೆ ಲಾಸ್ ಆಗಿದೆ. ಇವಾಗ ರೈತರು ಈ ಸಾವು ಏನು ಕರೋನಾದಲ್ಲಿ ಆಗಿದ್ಯೋ, ಈಗ ರೈತರ, ಅದರಲ್ಲೂ ಸಣ್ಣ ರೈತರು, ಅದರಲ್ಲೂ ಕೆಲವು ತರದ ಬೆಳೆಗಳಿಗೆ ಇದು ಆಗಿರುವಂತ ರೈತರು ಇನ್ನು ಮುಂದೆ ಸಾವುಗಳು ಇನ್ನೂ ಅತ್ಯಧಿಕ ಆಗುವಂತ ಪರಿಸ್ಥಿತಿಗೆ ಸಿಕ್ಕಾಕೊಂಡಿದ್ದಾರೆ. ಯಾಕಂದ್ರೆ ಇವರೆಲ್ಲರೂ ಈಗ ಸಾಲನೆ ಮಾಡಿದ್ದಾರೆ. ಆದ ಲಾಸ್ ಅನ್ನ ಮತ್ತೆ ಮುಂದಿನ ಸೀಸನ್ಗೆ ಹೋಗ್ಬೇಕಲ್ಲ, ಈಗ ಸುಮ್ನೆ ಕೂತ್ಕೊಳಕ್ಕಾಗಲ್ಲ ಅಲ್ಲ. ಹಾಗಾಗಿ ಅವರು ಈಗ ಮತ್ತೆ ಸಾಲ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ. ಎಲ್ಲೂ ಬ್ಯಾಂಕ್ ಲೋನ್ಗಳಿಲ್ಲ. ಬ್ಯಾಂಕ್ ಅಲ್ಲಿ ಈಗಾಗ್ಲೇ ಲೋನ್ ತಗೊಂಡು ಡಿಫಾಲ್ಟರ್ಸ್ ಇನ್ನೇನೋ ಮತ್ತೊಂದು ಆಗಿರೋದ್ರಿಂದ ಎಲ್ಲೂ ಇಲ್ಲ. ಸಿಕ್ಕವರಿಗೆ ಆ ಫಸಲ್ ಬಿಮಾ ಯೋಜನೆ ಅಂತ ಅಂದ್ಬಿಟ್ಟು 6-8% ಮುರ್ಕೊಳ್ತಾರೆ. ಅದು ರೈತರ ಗಮನಕ್ಕೆ ಕೂಡ ಬರ್ತಾ ಇಲ್ಲ. ನಮಗೆ ಏನು ವಿಮೆ ಕೊಡಿ ಅಂತ ಅಂದ್ರೆ ವಿಮೆ ಒಂದು 10% ರೈತರಿಗೂ ವಿಮೆ ಯಾವ್ದು ರಿಲಯನ್ಸ್ ಜನರಲ್ ಕಂಪನಿಗೆ ಕೊಟ್ಬಿಟ್ಟು 10% ರೈತರಿಗೂ ವಿಮೆ ಸಿಗ್ತಾ ಇಲ್ಲ. ಈ ಪರಿಸ್ಥಿತಿ ಒಳಗಡೆಗೆ ಇವತ್ತು ರೈತರು ಎಷ್ಟು ಸಾಲ ಮಿಡ್ಲ್ ಇಂದ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ ಅಂತಂದ್ರೆ ಹಳ್ಳಿಯ ದಲ್ಲಾಳಿಗಳಿಂದ. ಅವರು ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಅವರ ಸಾವುಗಳನ್ನ, ಕರೋನಾ ಸಾವು ಒಂದು ಕಡೆ ಆದ್ರೆ ಈ ಸಾವುಗಳನ್ನ ತಪ್ಪಿಸೋದು ಹೇಗೆ, ಇದು ನಮ್ಮ ಮುಂದೆ ಭೂತಾಕಾರವಾಗಿ ನಿಂತಿರುವಂತ ಪ್ರಶ್ನೆ. ನಿನ್ನೆ ತಾನೇ ನಮ್ಮ ಸ್ನೇಹಿತರು ಒಬ್ರು ಯಾದಗಿರಿಂದ, ಶಾಪುರಿಂದ ಫೋನ್ ಮಾಡ್ತಾ ಇದ್ರು. ಒಂದು ಕುಟುಂಬದಲ್ಲಿ 6 ಜನ ನಿನ್ನೆ ಆತ್ಮಹತ್ಯೆ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ. ಈಗ ಏನು ಒಂದು ವ್ಯಕ್ತಿ ಆತ್ಮಹತ್ಯೆ, ರೈತನ ಆತ್ಮಹತ್ಯೆ ಅನ್ನೋದು ನಡೀತಾ ಇತ್ತು, ಇವಾಗಿನ ಫಿನಾಮಿನಾ ನೋಡಿದ್ರೆ ಕುಟುಂಬಗಳ ಆತ್ಮಹತ್ಯೆ ಕಡೆಗೆ ನಡೀತಾ ಇರುವಂತದನ್ನ ನೋಡ್ತೀವಿ. ಈಗ ಸುಪ್ರೀಂ ಕೋರ್ಟ್ ಆರ್ಡರ್ ಬಂದಿದೆ ನಿನ್ನೆ ಮೊನ್ನೆ 29-30 ಜೂನು. ಈಗ ಕರೋನಾ ಸಾವಿಗೊಳಗಾದವರ ಕುಟುಂಬಗಳಿಗೆ ಕಾಂಪನ್ಸೇಷನ್ ಕೊಡಬೇಕು ಅನ್ನುವಂಥದ್ದು.
ಗಾಯತ್ರಿ, ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ನಾವು ಫೋಕಸ್ ಮಾಡ್ತಿದ್ವಿ, ಅದ್ರ ಬಗ್ಗೆ ಹೆಂಗ್ ಲಿಂಕ್ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು can you bring this with?
ಈ ಸಾವುಗಳು ನಮ್ಗೆ ತುಂಬಾ ಮುಖ್ಯ ಅಂತ ಅನ್ಸುತ್ತೆ. ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ನಿಜ, ಖಂಡಿತವಾಗಿ ಅದ್ರ ಬಗ್ಗೆ ಫೋಕಸ್ ಮಾಡೋಣ. ಈಗಾಗ್ಲೇ ಕೆಲವರೆಲ್ಲ ಹೇಳಿದ್ರು ನಾವು ಮುಖ್ಯಮಂತ್ರಿಗಳ ಹತ್ರ ಹೋಗ್ಬೇಕಾಗಿದೆ ಅನ್ನುವಂತ ಸನ್ನಿವೇಶನ. ಹಳ್ಳಿಗಳಲ್ಲಿ ಇವತ್ತಿಗೆ ತಾಂಡವವಾಡ್ತಾ ಇರುವಂತ ಭಯಂಕರ ಸನ್ನಿವೇಶಗಳು ಇವಾಗಿದ್ದೇವೆ. ಹಾಗಾಗಿ ಈ ಸುಪ್ರೀಂ ಕೋರ್ಟಿನ ಆರ್ಡರ್ ಏನು ನಮ್ಗೆ ಬಂದಿದೆ, ಅದನ್ನ ನಾವು ಮುಂದುವರಿಸೋದ್ರ ಬಗ್ಗೆ, ಸತ್ತೋದ ಕುಟುಂಬಗಳಿಗೆ ಕಾಂಪನ್ಸೇಷನ್ ಬಗ್ಗೆ, ಮತ್ತೆ ಮುಂದೆ ಈ ಮುಂದುವರಿಯೋ ಸಾವುಗಳನ್ನ ನಾವು ತಪ್ಪಿಸೋದ್ರ ಬಗ್ಗೆ, ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರಗಳಲ್ಲೂ ಪ್ರಾಯಶಃ ಉತ್ತರ ಇದಕ್ಕೆ ಸಿಗದೆ ಇರಬಹುದು ಈ ತರದ ಸಾವುಗಳಿಗೆ. ನೆಕ್ಸ್ಟ್ ಏನು ಅಂತಂದ್ರೆ ಅನಿಲ್ ಗುಪ್ತಾ ಅವರು ಆಶಾ ವರ್ಕರ್ಸ್ ನ ಒಂದು ಟ್ರೈನಿಂಗ್ ಬಗ್ಗೆ, ಅವರ ಇದನ್ನ ಸಂಬಳ ಹೆಚ್ಚು ಮಾಡೋದ್ರ ಬಗ್ಗೆ ಮಾತಾಡ್ತಾ ಇದ್ರು. ಅದ್ರ ಜೊತೆಗೆ ಈಗಾಗಲೇ ಕುರುಬೂರು ಶಾಂತಕುಮಾರ್ ಉದಾಹರಣೆ ಕೊಟ್ಟಿದ್ದಾರೆ. ನಮ್ಮಲ್ಲಿ ಆಶಾ ವರ್ಕರ್ಸ್, ಬೇರೆ ಹೆಲ್ತ್ ವರ್ಕರ್ಸ್ ಜೊತೆಗೆ ತುಂಬಾನೇ ಸಾವುಗಳನ್ನ ತಪ್ಪಿಸೋಲ್ಲಿ ಕೆಲಸ ಮಾಡಿದವರು ಸಿವಿಲ್ ಸೊಸೈಟಿ ವಾಲಂಟಿಯರ್ಸ್. ನಾವು ಕೂಡ ಕುರುಬೂರು ಶಾಂತಕುಮಾರ್ ತರಾನೇ ಒಂದು ಗ್ರೂಪ್ ನ ಹುಟ್ಟಾಕಿದ್ವಿ. ಅದರಲ್ಲಿ ಪ್ರತಿನಿತ್ಯ ರಾಮಯ್ಯ ಆಸ್ಪತ್ರೆಯ ಒಂದು ಗುಂಪು ಡಾಕ್ಟರ್ಗಳು ಬಂದು ನಾವು ಇದೇ ತರ ಗ್ರೂಪ್ ನ ಮಾಡಿ ಪ್ರತಿನಿತ್ಯ ಯಾರೇ ಫೋನ್ ಮಾಡಿದ್ರು ಅಲ್ಲಿಂದಲ್ಲಿಗೆ ಅವ್ರಿಗೆ ಉತ್ತರಗಳನ್ನ ಕೊಡ್ತಾ ಇದ್ರು. ಈಗಾಗಲೇ 2 ವಾಲಂಟಿಯರ್ಸ್ ಟೀಮ್ ಅನ್ನ ಅವರು ಟ್ರೈನ್ ಮಾಡಿದ್ದಾರೆ. ಆನ್ಲೈನ್ ಅಲ್ಲೇ ಆ ಟ್ರೈನಿಂಗ್ ನಡೆದಿದೆ. ತುಮಕೂರು ಜಿಲ್ಲೆನಲ್ಲಿ 50 ಜನ ನಮ್ಮ ಸ್ನೇಹಿತರು ಭೂಶಕ್ತಿ ಕೇಂದ್ರದಿಂದ 50 ಜನರನ್ನ ಟ್ರೈನ್ ಮಾಡಿದ್ದಾರೆ. ನೆಕ್ಸ್ಟ್ ಬ್ಯಾಚ್ ಬರ್ತಾ ಇದೆ. ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಆಶಾ ವರ್ಕರ್ಸ್ಗೆ ಫೋಕಸ್ ಮಾಡೋದ್ರ ಜೊತೆಗೆ ಸಿವಿಲ್ ಸೊಸೈಟಿಯ ವಾಲಂಟಿಯರ್ಸ್ ಏನಿದ್ದಾರೆ ಅವ್ರೂ ಕೂಡ ಈಗ ಮೊನ್ನೆ ಡಾಕ್ಟರ್ಸ್ ಮುಂದೆ ಅವರು ಇಟ್ಟ ಪ್ರಶ್ನೆಗಳಲ್ಲಿ 25 ಪ್ರಶ್ನೆಗಳು ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆನೇ ಇಟ್ಟಿದ್ರು ಅವರು. ಹಾಗಾಗಿ ಇದಕ್ಕೆ ನಿಜವಾಗ್ಲೂ ಸಿವಿಲ್ ಸೊಸೈಟಿ ವಾಲಂಟಿಯರ್ಸ್ ತುಂಬಾ ಮುಂದೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ಆದ್ರೆ ಅವರಿಗೇನು ಕೂಡ ಈ ತರದ ಟ್ರೈನಿಂಗ್ಗಳು ತುಂಬಾನೇ ಬೇಕಾಗಿದೆ. ಈಗ ಕೆಲವು ಡಾಕ್ಟರ್ಸ್ ಗ್ರೂಪ್ಗಳು ಈ ರೀತಿ ಮುಂದೆ ಬಂದಿದ್ದಾರೆ. ಆದ್ರೆ ಇದನ್ನ ನಾವು ಇನ್ನು ಹೆಚ್ಚು ಸ್ಟ್ರೀಮ್ ಲೈನ್ ಮಾಡ್ಬೇಕಾಗಿದೆ. ಇದನ್ನ ಇಲ್ಲಿ ಸ್ವಲ್ಪ ಸೀರಿಯಸ್ ಆಗಿ ತಗೋಬೇಕಾಗುತ್ತೆ ಅನ್ಸುತ್ತೆ. ಮತ್ತೆ ನಾ ಹೇಳಿದ ಹಾಗೆ ಹಳ್ಳಿಗಳಲ್ಲಿ ಈ ತರದ ಭಯದ ಒಂದು ಅಪನಂಬಿಕೆಯ ವಾತಾವರಣ ಸೃಷ್ಟಿಯಾಗಿರುವಂತ ಸಂದರ್ಭದಲ್ಲಿ ಮುಂದಿನ ದಾರಿ ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆ ನಾವು ಟೋಟಲಿ ಫೋಕಸ್ ಮಾಡಬೇಕು ಅಂತ ನನ್ಗೆ ಅನಿಸ್ತಾ ಇದೆ. ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ಗಳಿಗೆ ಈಗ ಸುಮಾರು 60+ ನವರಿಗೆ ವ್ಯಾಕ್ಸಿನ್ಗಳು ಎಲ್ರಿಗೂ ಆಲ್ಮೋಸ್ಟ್ ಆಗಿದೆ. ಇನ್ನು 45+ ನವರಿಗೆ ಎಲ್ಲೋ ಸ್ವಲ್ಪ ಭಾಗ ಆಗಿದೆ. ಅದ್ರ ಕೆಳಗಡೆ ಅವರಿಗೆ ಇಲ್ವೇ ಇಲ್ಲ. ಸಾವುಗಳಾಗಿರೋದು ಮಾತ್ರ ಎಲ್ಲಾ ಏಜ್ ಗ್ರೂಪ್ ನಲ್ಲೂ ಒಂದೇ ತರ ಸಾವುಗಳಾಗಿದೆ. ಹಾಗಾಗಿ ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ನಾವು ಸಂಪೂರ್ಣ ಫೋಕಸ್ ಅನ್ನ ಕೊಟ್ಟು ವ್ಯಾಕ್ಸಿನ್ ವಿಷಯದಲ್ಲಿ ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ಗೆ ಬನ್ನಿ ಅನ್ನೋದಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ ನಾವು ನೋಡಿರೋ ಪ್ರಕಾರ ಎಲ್ಲೆಲ್ಲಿ ಹಳ್ಳಿಗಳಲ್ಲಿ ಕ್ಯಾಂಪ್ ಹಾಕಿ ವ್ಯಾಕ್ಸಿನ್ ಮಾಡಿದಾರೋ ಅಲ್ಲಿ ಜನರು ತುಂಬಾ ಸ್ಪಂದಿಸಿರೋದು ಕಂಡು ಬರುತ್ತೆ. ಇಲ್ಲ ಅಂತಂದ್ರೆ ಜನರಿಗೆ ವ್ಯಾಕ್ಸಿನ್ ಬಗ್ಗೆ ಹುಟ್ಟಿರುವಂತ ಅಪನಂಬಿಕೆ, ಅಪಪ್ರಚಾರ ಅವರನ್ನ ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಸೆಂಟರ್ ಕಡೆಗೆ ಕರ್ಕೊಂಡು ಹೋಗ್ತಾ ಇಲ್ಲ. ಆಶಾ ವರ್ಕರ್ಸ್ ಎಷ್ಟೇ ಪ್ರಯತ್ನ ಬೀಳ್ಬಹುದು, ಆದ್ರೆ ಅದು ಕರ್ಕೊಂಡು ಹೋಗ್ತಿಲ್ಲ ಅವರನ್ನ. ಆದ್ರಿಂದ ಹಳ್ಳಿಗಳಲ್ಲಿ ಇದನ್ನ ಫೋಕಸ್ ಮಾಡೋದ್ರ ಬಗ್ಗೆ, ಕ್ಯಾಂಪ್ಗಳನ್ನ ಮಾಡೋದ್ರ ಬಗ್ಗೆ ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ತುಂಬಾನೇ ನಾವು ಒತ್ತು ಕೊಡ್ಬೇಕಾಗುತ್ತೆ ಅಂತ ಅನ್ಸುತ್ತೆ. ಈ ಹೈಟೆಕ್ ಆಸ್ಪತ್ರೆಗಳ ಬಗ್ಗೆ ಹೇಳ್ತಾ ಇದ್ರು ಮೇಡಮ್ನವರು, ಕಿರ್ಲೋಸ್ಕರ್ ಮೇಡಮ್ನವರು, ಬಳ್ಳಾರಿನಲ್ಲಿ ಜಿಂದಾಲ್ನವ್ರು ಮಾಡಿರುವಂತದ್ದು. ಆದ್ರೆ ಅಲ್ಲಿ ಅಂತ ಹೈಟೆಕ್ ಆಸ್ಪತ್ರೆ ಆಗಿರೋ ಸಂದರ್ಭದಲ್ಲೂ ಒಂದು ಸಮಯದಲ್ಲಿ ಬಳ್ಳಾರಿಯಿಂದ ಹೈಯೆಸ್ಟ್ ಸಾವುಗಳು ಬರ್ತಾ ಇದ್ದು. ಹಾಗಾಗಿ ಇವತ್ತು ಬರೀ ಆಸ್ಪತ್ರೆಗಳು, ಎಕ್ವಿಪ್ಮೆಂಟ್ಸು, ಹಣ ಇವುಗಳಿಗಿಂತ ಹೆಚ್ಚಾಗಿ ಇವತ್ತು ಜನರ ಜೊತೆ ನಿಂತು ಸ್ಪಂದಿಸುವಂತ ಪಡೆ ನಮ್ಗೆ ಇವತ್ತು ಬೇಕಾಗಿದೆ. ಅದನ್ನ ಕಟ್ಟೋ ಕಡೆಗೆ ನಾವು ತುಂಬಾನೇ ಫೋಕಸ್ ಮಾಡ್ಬೇಕಾಗುತ್ತೆ ಅಂತ ಅನ್ಸುತ್ತೆ. ಮತ್ತೆ ರೈತರು ಇವತ್ತು ಸಿಕ್ಕಾಕೊಂಡಿರುವಂತ ಸ್ಥಿತಿ ಅದು ಇರ್ರೆಲವೆಂಟ್ ಅಂತ ಖಂಡಿತ ದಯವಿಟ್ಟು ಇಲ್ಲಿರೋರು ಯಾರು ಭಾವಿಸ್ಬೇಡಿ. ಅದಕ್ಕೂ ತಾವೆಲ್ಲರೂ ಸ್ಪಂದಿಸ್ಬೇಕು ಅಂತ ನಾನು ಕೇಳ್ಕೊಳ್ತೀನಿ. ದಟ್ಸ್ ಆಲ್. ಥ್ಯಾಂಕ್ ಯು.
ಥ್ಯಾಂಕ್ ಯು ಗಾಯತ್ರಿ. ಈಗ ನಾವು ಸೀರೀಸ್ ಆಫ್ ವೆಬಿನಾರ್ ಮಾಡ್ಬೇಕು ಅಂತ ಯೋಚನೆ ಮಾಡ್ಕೊಂಡಿದ್ವಿ. ನೆಕ್ಸ್ಟ್ ವಿಚಾರ ಬಹುಶಃ ರೈತರ ಬಗ್ಗೆನೇ ಫೋಕಸ್ ಮಾಡಬೇಕು. ರೈತರು ಅದನ್ನ ಯಾಕೆ ದಟ್ ಇಸ್ ಮೈ ಇಂಟ್ರೆಸ್ಟ್ ಅಂಡ್ ಐ ಕ್ಯಾನ್ ಡೂ ಸಮಥಿಂಗ್. ಅದು ಖಂಡಿತ ತಗೊಳ್ತೀವಿ. ಥ್ಯಾಂಕ್ಸ್ ಫಾರ್ ಪ್ರೊವೈಡಿಂಗ್ ದಟ್ ಇನ್ಪುಟ್. ಈಗ ರೈತರ ವಿಚಾರನ ನೆಕ್ಸ್ಟ್ ಇಶ್ಯೂ ವಿಲ್ ಬಿ ಡೆಫಿನೆಟ್ಲಿ ಆನ್ ದಿ ಫಾರ್ಮರ್ಸ್. ಎಸ್ಪೆಷಲಿ ನೀವು ಹೇಳಿದ್ರಲ್ಲ, ಬೆಳೆತಿರೋದನ್ನು ಒಂದೇ ಒಂದು ರೈತರು ಬೆಳೆದಿರತಕ್ಕಂಥ ಕಾಳು, ಒಂದು ಹನಿ ಹಾಲು ಕೂಡ ಹಾಳಾಗಕೂಡದು. ಅದು ಈ ಸಂದರ್ಭದಲ್ಲಿ ದಟ್ಸ್ ಎ ನ್ಯಾಷನಲ್ ಕ್ರೈಮ್ ಅಂತ ನನ್ನ ವೈಯಕ್ತಿಕ ಅಭಿಪ್ರಾಯ. ಥ್ಯಾಂಕ್ಸ್ ಲಾಟ್. ಈಗ ಇನ್ನಿಬ್ಬರು ನಾವು ಕರೆದಿದ್ದು, ಪ್ರಸನ್ನ ಅವರು ಮಂಡ್ಯದ ಮೂಲಲ್ಲಿ ಯಾವ್ದು ಹಳ್ಳಿಯಲ್ಲಿ ಪಾಪ ಇದ್ದಾರೆ. ಪ್ರಸನ್ನ ಎನ್ ಗೌಡ ಅವರು ಇದ್ದಾರಾ? ಇಲ್ಲ. ಅಭಯ್ ಅವರು, ಅವ್ರಿಗೆ ಕಷ್ಟ ಆಗಿದೆ ಪಾಪ, ಮಳೆ ಆಗ್ತಿದೆ. ರಾಜಾರಾಮ್ ತೆಲ್ಲೂರ್, ರಾಜಾರಾಮ್ ಓಕೆ ಇಲ್ಲ ಅಂತ ಕಾಣುತ್ತೆ. ಬಹುಶಃ ನಮ್ಮ ಯೋಚನೆಗಿಂತ 20 ನಿಮಿಷ ಜಾಸ್ತಿ ಆಯ್ತು. ನಾವು ಪ್ರಾರಂಭಿಸಿದ್ದು ಒಂದು 5-10 ನಿಮಿಷ ತಡ ಆಯ್ತು. ಹಾಗಾಗಿ ಹೆಚ್ಚು ಕಡಿಮೆ ಈಗ ಇದು ಒಂದು ಸಮಯದ ದೃಷ್ಟಿಯಿಂದ ಕೂಡ ಶಿಸ್ತುಬದ್ಧವಾಗಿದೆ. ಹಲವಾರು ಜನ ಬಂದಿದ್ರಿ. ನಮ್ಮ ಸೇಜ್ ಗುಂಪಿನಿಂದ ವೇಣುಗೋಪಾಲ್ ಆಗ್ಲಿ, ಯಾರಾದ್ರೆ ನಮ್ಮ ಇನ್ಯಾರಿದ್ದಾರೆ, ಶ್ರೀವತ್ಸ ಅವರಿದ್ದಾರೆ. ಸೇಜ್ ನಮ್ಮ ಸ್ನೇಹಿತರು ಏನಾದ್ರು ಹೇಳೋದು ಅಂತಂದ್ರೆ 1-2 ನಿಮಿಷದಲ್ಲಿ ಅವಕಾಶ ಕೊಟ್ಟು ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮ ಮುಗಿಸ್ತೀವಿ. ವಿ ಶಲ್ ವೈಂಡ್ ಅಪ್ ದಿ ಪ್ರೋಗ್ರಾಮ್. ಎನಿಥಿಂಗ್ ಫ್ರಮ್ ಅವರ್ ಸೇಜ್ ಫ್ರೆಂಡ್ಸ್? ಪ್ರತಾಪ್, ನವೀನ್? ಪ್ರತಾಪ್ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿಕೊಳ್ಳಿ. ಪ್ರತಾಪ್ ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಾ ಇಲ್ಲ.
Nothing from me, and if anybody else would like to speak, because hardly anybody is left now. Any of our core or the SAGE members would like to speak, please go ahead.
ಯಾರಾದಿದ್ರೆ? ಓಕೆ, ಯಾರು ಇಲ್ಲ ಅಂತ ಕಾಣುತ್ತೆ. ಓಕೆ, so it's a very fruitful discussion in a limited capacity. Individually we joined together to form ಸೇಜ್. ತಾವ್ ಏನ್ ಮಾಡ್ಬೋದು ಅದನ್ನ ಮಾಡಿದ್ವಿ. ರಿಯಲಿ ಇಟ್ಸ್ ರಿಅಶ್ಯೂರಿಂಗ್. ಯಾಕೆಂದ್ರೆ ನಾವು ಸರ್ಕಾರದ ಮುಂದೆ ತಗೊಂಡು ಹೋಗೋದಕ್ಕೆ ಅಂತೇಳಿ ಈ ಸಂದರ್ಭದಲ್ಲಿ ನಾನು ಕಳೆದ ಬಾರಿ ಮಾಡಿದಾಗೆ ಮತ್ತೊಮ್ಮೆ ನಾವೆಲ್ಲ ಕೂತು ಚರ್ಚಿಸಿ ಬಂದಂತ ವಾಟ್ ಆರ್ ದಿ ಕೀ ಇಶ್ಯೂಸ್ ಹ್ಯಾವ್ ಬಿನ್ ಎಮರ್ಜ್, how we can put forth before the government. ಯಾಕಂದ್ರೆ government is not in a position to understand, implement. ಯಾಕೆ suggestions are coming from different quarters. But ಇವಾಗ ನಮ್ಮ ಗೀತಾಂಜಲಿ ಮೇಡಮ್ ಅವ್ರ ಜೊತೆಗಿರೋದ್ರಿಂದ she is also assured something, so that ಇವತ್ತಿನ ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಎದ್ದಿರತಕ್ಕಂತ ವಿಚಾರಗಳನ್ನ ಸರ್ಕಾರದ ಮುಂದಿಟ್ಟು ಕೆಲವನ್ನಾದ್ರೂ ಕೂಡ ಈಡೇರಿಸ್ಕೊಳ್ತಕ್ಕಂಥ, ಅದರಲ್ಲೂ ಮುಖ್ಯವಾಗಿ ಇವತ್ತಿನ ಫೋಕಸ್ ಇಸ್ ಎಕ್ಸ್ಕ್ಲೂಸಿವ್ಲಿ ಆನ್ ದಿ ರೂರಲ್ ಹೆಲ್ತ್ ಸಿಸ್ಟಮ್ಸ್. ಅದ್ರ ಬಗ್ಗೆ ವಿ ಕ್ಯಾನ್ ಡೂ ಜಸ್ಟಿಸ್. ಎಕ್ಸಲೆಂಟ್ 3 ಸ್ಪೀಕರ್ಸ್ಗಳು ಇದ್ರು, ಫಾಲೋಡ್ ಬೈ ಗೀತಾಂಜಲಿ ಮೇಡಮ್ ಅವರು ಕೂಡ ವೆರಿ ಆಕ್ಟಿವ್ ಆದ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ಗಳಾಯ್ತು, ಕ್ವಶನ್ ಆನ್ಸರ್ಗಳಾಯ್ತು. ಶಾಂತಕುಮಾರ್ ಅವರು ಒಳ್ಳೆಯ ಸಲಹೆಯನ್ನು ಕೊಟ್ಟಿದ್ದಾರೆ. ಗಣೇಶ್ ಕಾರ್ನಿಕ್, ಸುದರ್ಶನ್ ಅವರು ಒಂದು ಪಕ್ಷ ರಾಜಕೀಯ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಯಾವ ರೀತಿ ಮಾಡಬಹುದು ಅಂತ ಅಶ್ಯೂರೆನ್ಸ್ ಕೊಟ್ಟಿದ್ದಾರೆ. ಡೆಫಿನೆಟ್ಲಿ ಫ್ರಮ್ ದ ಸೇಜ್ ಪಾಯಿಂಟ್ ಆಫ್ ವ್ಯೂ ಇಟ್ ಈಸ್ ವೆರಿ ಸ್ಯಾಟಿಸ್ಫೈಯಿಂಗ್ ಒನ್, ಅಂಡ್ ವಿಲ್ ಅಶ್ಯೂರ್ ಯು ದಟ್ ವಿಲ್ ಟೇಕ್ ದಿಸ್ ಫಾರ್ವರ್ಡ್. ಅಂಡ್ ಆಲ್ಸೋ ಗಾಯತ್ರಿ ಅವರು ಹೇಳಿದಂಗೆ ಹಲವಾರು ವಿಚಾರಗಳನ್ನು ಎತ್ಕೊಳ್ತೀವಿ. ಇಷ್ಟನ್ನು ಹೇಳ್ತಾ ಬಂದಂತ ಎಲ್ಲರಿಗೂ ಕೂಡ ವಂದಿಸ್ತೀವಿ. ಇವತ್ತಿನ ಸಭೆಯ ಸಂಪೂರ್ಣವಾದಂತ ಯೂಟ್ಯೂಬ್ ರೆಕಾರ್ಡ್ ಅನ್ನು ನನ್ನ ಮಿತ್ರ ಅಂತ ನವೀನ್ ಅವರು ಮಾಡಿದ್ದಾರೆ. ಇವತ್ತಿನ ವೆಬಿನಾರ್ ನಿರ್ವಹಣೆಯನ್ನು ಅವರೇ ಮಾಡಿದ್ದಾರೆ. ಹಾಗಾಗಿ ಅವರಿಗೆ ನಾನು ಕೃತಜ್ಞತೆ ಹೇಳ್ತೀನಿ. ಈಗ ಯೂಟ್ಯೂಬ್ ರೆಕಾರ್ಡಿಂಗ್ ನ ತಕ್ಷಣ ನಿಮ್ಗೆಲ್ಲ ಕಳಿಸ್ತೀವಿ. ವಿತ್ ಇನ್ ಎ ವೀಕ್ ಅಲ್ಲಿ ಆ ಪ್ರೊಸೀಡಿಂಗ್ಸ್ ಗಳನ್ನ ಕನ್ನಡದಲ್ಲಿ ತರಕ್ಕೆ ಪ್ರಯತ್ನ ಪಡ್ತೀವಿ. ಬಂದಂತ ಭಾಗವಹಿಸಿದ ಎಲ್ಲರಿಗೂ ಕೂಡ ನಾನು ತುಂಬಾ ಆಭಾರಿಯಾಗಿದ್ದೀನಿ. ಜೊತೆಗೆ ಸಹಕರಿಸಿದಂತ ಪ್ರತಾಪ್ ಹೆಗಡೆ ಅವರಿಗೂ, ನವೀನ್ ಅವರಿಗೂ, ವೇಣುಗೋಪಾಲ್ ಅವರಿಗೂ, ಹಲವಾರು ಮಾಧ್ಯಮ ಮಿತ್ರರು ಬಂದಿದ್ರು. ಮಧ್ಯ ಅವರು ಇರಕ್ಕಾಗಲ್ಲ, ಹೋಗ್ತೀನಿ ಅಂತ ಹೇಳಿದ್ರು. ಅವರೆಲ್ಲರಿಗೂ ನಾನು ವಂದಿಸ್ತೀನಿ. ಮತ್ತು ಗೀತಾಂಜಲಿ ಅವರು ಕಾರಣಾಂತರದಿಂದ ಹೋಗ್ಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಅಗೇನ್ ಶಿ ಪುಟ್ ಮೆಸೇಜ್ ದಟ್ ಶಿ ವಿಲ್ ಬಿ ವಿತ್ ಅಸ್. ಶಮಾ ಕಾರಕಲ್ ಅವರು, ಪ್ರಶಾಂತ್ ಅವರು ಎಲ್ಲರೂ ಇದ್ದಾರೆ ಅಂತ ಅವರೆಲ್ಲರಿಗೂ ವಂದಿಸಿ ಈ ಒಂದು ವೆಬಿನಾರ್ ಸಭೆಯನ್ನು ಈಗ ಮುಗಿಸಲಾಗುತ್ತದೆ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
ಥ್ಯಾಂಕ್ ಯು.